Are we live, Shiva?
Yeah, it's live.
Good morning, everybody, and welcome to this fifth edition of One Talk, One Speaker. I'll go through the disclaimer in the beginning. We thank our faculty, Dr. Milind Chaudhary, for sharing his knowledge and expertise, especially in these challenging times. We wish all our audience a healthy and safe day ahead. These webinars are dependent on internet speed and technology, and it might be unstable at times, so bear with us. I'll also show you how to ask questions on the website. Phone numbers to ask questions are also shared. However, this is our Ortho TV page where you can see us live. Now, just below the video, you have the question answer panel. You can type your questions here. So you can type the questions and send to us. Over to you, Shiva sir, for the proceedings.
Thank you very much. Friends, today we have a international personality as a speaker for One Person, One Talk. He will be sharing his vast experience about the Ilizero deformity courses and other deformity correction surgeries. So this is none other than Dr. Milind Chaudhary from Akola. He runs the Center for Ilizero Techniques at Akola in Maharashtra. He has lots of recognitions. He is honored as the professor of Ilizero in the Center Kurgan at the original Ilizero Institute. He has got the highest award in the Rotary, that is service above self. For all the Rotarians, they will be knowing that this is like Bharat Ratna in Rotary. That is the highest award any Rotarian can, any Rotarian or a non-Rotarian can get. He has also given the BOS award, that is the Young Surgeons Forum in 1998 when he was young, under 40 years of age. And when he was older, again, he has got the opportunity to give the Veteran Surgeons Award in 2014 in the Bombay Orthopedic Society's YROC, one of the most awaited academic feast in orthopedic world. He has been invited to many national and international conferences. Some of the international conferences are controversies in pediatric limb reconstruction in Asami, Japan, then Hull deformity course in England, then first Asami ILRS Congress in Miami, then Baltimore deformity course in 2003, 2004, and 2005. He has many publications. Few of the important ones are in the Journal of Limb Reconstruction Surgeries. Incidentally, Dr. Milind Chaudhary is the editor of this journal. It's an international journal. He has also written article about double-level fixator-assisted nailing in JBGS, infected non-union of tibia in IJO, Indian Journal of Orthopedics, then infected distal tibial non-union in JLLR, surgical dislocation of hip in IJO, lengthening over a nail in IJO, Taylor spatial frame in IJO, then treatment of thromboangiitis obliterans by bone widening in IJS. Is also written in OCNA, the treatment of malunions and mal non-unions. Friends, this is my friend, Dr. Milind Chaudhary, whom I had the opportunity to meet and listen during the recently held AsamiCon in February, last week of February at New Delhi. So this is now Dr. Milind Chaudhary for all of you. He'll be giving his talks in gradually, as he is talking about the evolution. He will be giving the first generation Ilizero, then next generation, how it changed everything. So in between, we have got time to ask questions. The question answer will be in between and also the last part of the talk. I will hand over the proceedings now to Dr. Milind Chaudhary. Milind, you can start sharing. Yes.
Can you see?
Yeah, fine.
Good morning. Thank you, Shiva, and thank you, Ashok, It's really a privilege to be amongst you. And it's really a privilege that I have and an honor that I have the opportunity to speak about the subject that's really very close to my heart, the evolution of limb lengthening and deformity correction as a specialty in orthopedics. And the interesting thing about this is it's not going to be a theoretical talk about some arcane technologies. It's going to be something that I have experienced and seen up close and personal, because serendipity has thrown me right in the ring seat of the evolution of deformity correction as the new science. So this talk is going to be about the principles of deformity correction, the procedures that are done, the various procedures, the various hardware, how it evolved over a period of time, and very interestingly, some of the great personalities that I had the absolute honor and privilege of interacting with very closely in this journey. But first of all, no talk on deformity correction can be complete without first paying obeisance to the great master of deformity correction. This is a painting that adorns my consulting chamber, and it has been with me for the last 30 years. Very kindly given to me by my dear mother, as if to signify, in the words of Ambroise Paré, that I merely do the dressing and he heals the wounds. So this is the picture of the Ashtavakra Kubja, whose scoliotic and other 7 deformities are being corrected using the 3-point principle by Sri Krishna. Coming more to modern times, Marshall McLuhan said, "We shape our tools, and afterwards our tools shape us." So we all know very well that from the days of millions of years ago, when we had crude tools and we could only do so much, today's the tools that we have for deformity correction are enabling us to do unbelievable things. First, we create our tools, and then finally, our tools shape our thinking, shape our behavior, and shape our possibilities. So let me begin by talking about the first generation of deformity correction. The 1G actually started in 1757. This is a transcript of a translation of the French article by Nicolas Andry, translated into London. And the date stamp on this is 1775 or 77. And this is orthopedia. Now you may be wondering what's so special about deformity correction. And you would not be wrong if you thought that orthopedics is straightening crooked children, and all orthopedic surgeons are really specialists in deformity correction. That is very true. And that was the case until very recently. So Nicolas Andry and his principles held the roost for 200 years. And all of us practice various different ways. Very recently, 30 years ago, the British Journal of Bone and Joint Surgery ran an editorial which said Nicolas Andry and 250 years of orthopedy. I looked at some issues in the British and American Journal of Bone and Joint Surgery for some examples of deformity corrections. And what I found, it typified the kind of deformity correction we were performing. Now look at the X-ray on the left of the screen. This is a valgus deformity and procurvatum. I have drawn the axis lines here in the center. And on the right, you can see how the surgeon has corrected. This is from London. He has performed a varicizing osteotomy very high up in the middle of the tibia, as a result of which there is a dramatic amount of varus here. Though the joint line has been straightened, there is a dramatic translation that persists. And this goes on to signify one of the big drawbacks of Nicolas Andry's and the first generation method. We all could do osteotomies. We all have seen great surgeons performing osteotomies in a few minutes. But very often, these osteotomies left a lot to be desired. Let's look at one more example. This is a varus and procurvatum in the femur from the American Journal of Bone and Joint Surgery. And after an osteotomy, you can see that the deformity is not really completely corrected. So the completeness of correction, determining what is complete or not, was not there. Look at the x-rays of this valgus in the femur and the tibia. This valgus has been corrected by a valgizing osteotomy in the upper tibia. And notice that the joint line is still oblique. On the x-ray to your right, there is a dramatic shift of the distal fragment. Even though the varus may be corrected visually and clinically, it may be all right, it is certainly going to lead to problems later. So if we are to look with a bird's eye view about the problems of the first generation, firstly, there was no understanding, there was no codification, there was no classic nomenclature, there were no rules. The goals of treatment were very simple. Correct the deformity, let it look straight. You won over the day, Baji Marli, we did it for the moment, for the hour. But we had no clue how long it's going to last. About the duration of the results and the repercussions, there was no clue. And secondly, we had no clue about the joint orientation. And finally, the hardware that was used, that was plaster casts. Many high tibial osteotomies, varus corrections were done with a plaster cast, in which it led to compartment syndromes. The plaster became loose, the deformities were uncorrected. So there were problems of stability. You could not perform multi-level corrections, and you could not have range of motion. You had stiffness of the joints. So all these are the problems of the first generation. Though it is simple, you can perform percutaneous osteotomies. We did not consider what is happening to the joint orientation. We could not lengthen the limbs. There were secondary deformities that were created, such as translation, and the rotation, of course, was neither understood nor corrected. So let me begin with my personal journey very, very briefly. I joined St. J.S. Medical College in 1977. As an undergraduate student, it was always considered the creme de la creme of medical schools in India. But especially during my time, two batches coalesced. The first batch of 10 plus 2 was my batch. And prior to that was the interscience batch. And two batches of creme de la creme students combined to get into this huge hotspot that was the GS batch of 77, which is the most brilliant students. And surely my ego took a big battering immediately. But it was a foundry, it was the nursery, it was the place where I grew up. And I was very lucky to do my orthopedic residency in KM Hospital from 1983 to 1987. Now, three things stand out from my duration in my residency, three very salient features. And I address this to the younger surgeons and the older ones, and my dear colleagues, and Shiva, you may kindly forgive me. First of all, we had no power equipment. We had very few equipment. We had no power equipment. We had no C-arms. So immediately two things happened. We had to develop the can-do spirit. We had to be fast, and we had to develop our skills to drill fast, to get judgment, to get orientation, to get 3D and spatial orientation. The second very important thing that happened, and it shaped me as an orthopedic surgeon, were the Thursday clinical meetings at KM Hospital. I remember every Thursday in the morning, 7 or 8 of our bosses, honoraries, most of them, gathered. It was a galaxy of stars, orthopedic stars. Dr. Ellen Vora, Dr. Bhandari, Dr. Pradhan, Dr. M.N. Shahane, Dr. Bavdekar, Dr. Dheer, Dr. Saraf, Dr. B.R. Patel, wonderful teachers. And we presented cases as residents, and we always had these bosses give completely different opinions. And we realized very soon that neither of their opinions was wrong. So very beginning of my orthopedic education, I learned to open my mind to a multitude of answers to any given problem. This was my nursery, this was my school. And most important in those days, the third factor is you had very few investigations apart from x-rays. We had to rely on blood tests and x-rays. So therefore, we developed clinical acumen. So then let me move on. As an orthopedic resident, I knew that we were always trying to do the latest things. Arthroscopy was coming in, total hip replacement was coming in, and we were all excited. Our teachers were excited, we were excited. We wanted to do these. But our high-tech aspirations in the operation theater were very different and disconnected from the reality that was parallel. You know, those are the times when Parel was a mill chawl area where the poor mill workers lived. It was a very crowded place in Mumbai. And if you just stood outside your hostel and if you watched the parade of people going through, you could see 10% of them had a limp. You could see deformities, you could see contractures, you could see people walking with a limp. And if you went back to Campbell's Orthopedics, you did not see much on limb lengthening. You did not see much on deformity correction. You never saw these cases in the operation theater. So this stuck in my mind. A very landmark event happened in the Bombay Hospital in 1986, the Conference of Surgery in the Tropics. Dr. Murarilal Saraf will remember this. Professor Elizarov came. In his sunset years, he decided to travel around the world and he made a presentation in India. And all of us young surgeons were falling out of our chairs. We were seeing something unbelievable and impossible to believe. And we were all excited. A lot of the cynical seniors amongst us said, "Are ye apne ko," pardon the unparliamentary language, "chutiya bana raha hai. Ye sab हाथ का खेल है, ऐसा हो ही नहीं सकता. He cannot lengthen so many things. He cannot shape the bones. He cannot correct such deformities." But the younger ones amongst us really wanted to know and wanted to learn this. Well, after that, I had a chance to work at the wonderful Children's Orthopedic Hospital in Haji Ali for 6 months, where I developed a lifelong love for club feet and a deep understanding based on the two great teachers whom I saw working and operating over there. Also polio, also cerebral palsy. I had the great privilege of watching very closely Captain Perin Mullah Firoz, captain of the British Indian Army who saw action in Indonesia, who set up the cerebral palsy unit and ran it with an iron fist and great discipline. Thereafter, I spent a year in England in Sunderland District General Hospital. A couple of things stand out during this sojourn. One is constantly the poem was running through my head. Here breathes a man with a soul so dead, who never to himself had said, "This is my own, my native land." And these were my feelings because I could not forget what the British rule had done to us. I wasn't terribly happy. I wasn't really enamored by the total hip replacements, the total knee replacements, and the arthroscopies they were doing because I knew I wanted to come back to Akola and I wanted to serve our people. So it was a brief period. I didn't last there for more than a year. At the first opportunity, I ran to this conference in New York City at the Omni Park Central. I had to work 10 days in a row to get permission to go to this conference because Elizarov was coming to the USA for the first time and there was a conference. And I had this wonderful opportunity to see Professor Elizarov and this very smart young man who was conducting the whole proceedings with a tremendous gift for explaining things in English. And that was Jor Paley. And I had the opportunity to get a fellowship in the Shock Trauma Center of University of Maryland, but I gave it up for a fellowship with Dror. And here is Dror with Professor Elizarov when he visited, when I was there in 1988 at the University of Maryland. And after 6 months of learning, that was a wonderful time because Dror is hardly a couple of years older than me. And this great distance that we had between us and our teachers in Mumbai wasn't there. And I could see the way his mind thought. And I saw him at very close quarters. And since I didn't have many clinical responsibilities, for the first time I could think and try to understand. He had this fantastic board, on which he could digitize X-rays. And the first principles of deformity correction were formulating in his mind as he used the digitizer board to convert the X-rays onto the PCs. And I was playing with the whole thing until the middle of the night when I started getting a sense of deformity correction. So when I came back to India, a surprising thing happened. I realized I have no equipment. And the next 1.5 years were spent in places, as you can see on this map, in Nagdevi Cross Lane, in Lohar Chal, in the Andheri industrial areas, and also in Pune, in Bhosri MIDC, in Pimpri Chinswad, trying to make the Elizarov apparatus affordable for the people whom I wanted to treat. India, in 1989, 1990 was very different. We had lots of time. We had always had skills. People didn't have a lot of money. And so I spent a lot of effort trying to make the Elizarov apparatus till it became available and affordable so that I could get a head start. And instead of osteotomes and instead of surgeries and X-rays and I had to spend a lot of time with CNC lathes, thread rolling, laser cutting, and what have you. So this concludes the first part of the first generation of deformity correction. We will very soon go on to the next part, where we actually started with the Elizarov techniques. So I'll take a break here so that Shiva may want to ask me questions and we can prepare for the next part. Thank you.
Yes, that was wonderful introduction to your love for Elizaro and how, as an orthopedic surgeon, you came across Dr. Elizaro himself, and also the man who brought Elizaro to the whole world, actually, Dr. Dwarf Palais. I have read an article written by Dr. Elizaro Dwarf Palais himself, that he was working in Canada and he wanted to learn the deformity corrections so much. Then he couldn't get to work with Elizaro himself. So he spent many years in France, Italy, learning those techniques. Then subsequently, when Elizaro met him sometime, then he offered him to work under him. Then he went to Elizaro repeatedly. All those things I have heard. But the one interesting thing I read in that article was Dr. Dreyer Palais has mentioned with great reference to Dr. Milind Chaudhary that Milind was my first fellow. So how was your experience being the first fellow of Dr. Dreyer Palais himself?
Oh, this is very interesting. You're taking me back a long time in history. It was a very different experience. I had passed my ECFMG, but I didn't have the state license to operate. So I could not wash up in most of the cases. So in order to be helpful and in order to see things at close range, I ran drawers Siam most of the time because his technicians were always playing hooky. And I helped in analyzing, gathering his x-rays, analyzing his x-rays. And since he realized that I was good talking to patients, he always had me by his side when we were following a patient because he didn't want to be caught up talking to patients for a long time in the follow-up. It was a wonderful experience. It opened my mind. For the first time, I could think as an orthopedic surgeon. Till then, for 4.5 years, I was only working. Of course, we had great experiences in places like KM. Professor Ellen Vora told us he had the Socratic method of teaching. He only asked questions. He didn't give answers. He made us think. And more or less the same thing continued because George told me in the beginning, don't ask me too many questions. If you need to ask me at the end of the day. So I learned to observe and to try and understand on my own. God was very kind to me. And I learned a lot by observing him and by reading his notes. And this kind of shaped my period of observation. For the first time, I could take a look at an X-ray and rattle off 20 things that I would have never done so before having done this fellowship. So those were interesting times. Yes. And we were at the cutting edge of the science.
Okay, I think we can move on to the next presentation.
Okay.
Because I'll ask questions once you do some presentation, because this was introduction. So my question was also introductory.
So now let's move on to the second generation of deformity correction. This is 2G. As you know, 2G in telephony. But let's go back to Archimedes. If he said, give me a lever long enough and a fulcrum to place it and I can move the world, possibly, Gavril Abramovich Elizarov said, give me a hinge and a stable fixator and I can correct any deformity in the world. And that would not be far from the truth. So the second generation of deformity correction really began with the Elizarov method. And this is the landmark book of Professor Elizarov, which was translated by the great Stuart Green. This is a photograph of me taken with Professor Elizarov in Baltimore in 1988, I think, or 89. And I went to Kurgan a couple of times. And I had the privilege of meeting Professor Elizarov on both the occasions over there, as well as once in Mumbai after I came back. So not only this book, which is really a Russian Bible, but Professor Elizarov gave us the law of tension stress. He didn't just give us an apparatus. He empowered us with the biological principles to heal tissues, to grow tissues, to create new tissues. He did it in Kurgan, a very small town in Siberia in the middle of nowhere. And we now do it all over the world. You know the Elizarov external fixator. It's a very simple fixator, nothing very flashy about it. You know, rings, threaded rods, hinges, wires, pins, simple kind of assembly. But it really got codified in the English language with this great work of Dror, which is the Principles of Deformity Correction. This is a photograph taken with Dror at the beginning of the new center that they set up in Baltimore. This is 2001. So what the Principles of Deformity Correction gave us, what Dror gave us at that time, was deformity nomenclature. There was a standard way of classifying deformities, and hopefully this animation will show you. The most important thing we learned was we need full-length X-rays. And on those full-length X-rays, there were a few important deformity parameters, like these angles around the knee joint, the MLDFA 87, MPTA 87, LDTN 90. These are the crucial angles we had to know. Similarly, on a lateral full-length X-ray, the very important angles were around the knee joint. And if we knew these, we would know what is going on with the deformity. So here you have the posterior proximal femoral angle, the anterior neck shaft femur angle, which is 10 degrees or 170, the posterior distal femoral angle of 83 degrees, and this is the proximal tibial angle proximally at about 78 to 81 degrees, and distally at the ankle 80 degrees. So the second thing that we came to know were the osteotomy rules. And I hope to be able to demonstrate these with this animation, okay? I address this talk more or less to my younger friends so that they may be exposed to this. This is an idealized diagram of a tibia with a deformity. We draw the axes of the proximal fragment and the distal fragment. They intersect at the cora, center of rotation of angulation. There is a transverse bisector line, which is also the axis of correction of angulation. If you place a hinge at the concave cortex and remove a triangle of bone and you close it, you correct the deformity, you correct the axis, but you get a little bit of shortening and there is no translation. If you place the hinge at the convex cortex and gradually distract it apart, you get a triangular shaped regenerate bone, correct the deformity, correct the axis, and you don't have shortening. If you wanted to lengthen the bone, you just place the hinge away from the convex cortex so that you regenerated a wedge-shaped bone. Now, what if you could not perform the osteotomy exactly at the level? If you place the hinges correctly on the axis of correction of angulation, but perform the osteotomy anywhere else, the overall axis always lined up, like so. If the hinge is placed at the axis of correction, over here, the translation will occur at the osteotomy site, but the overall axis will line up. This is also known as the angulation translation osteotomy and is a crucial part of understanding most deformity corrections because most deformities we see arise at the metaphyseal areas, okay? So the deformity is corrected, the axis is corrected, there's a little translation. Now, if you place the hinge at the convex cortex and do the same way, you get a little translation along with lengthening, but the axis lines up. This is also something we use on a regular basis, okay? Now, these two rules form the very basis. Remember, this is the transverse bisector line, which is the axis of correction of angulation. Remember that you need to place the hinges on the axis, and remember that you should try and perform the osteotomy as close to the axis as possible. If it is not possible, if you go away from the axis, then you will get some translation, but the axis will correct. And then there is a rule 3, which we rarely use, in which we inadvertently or on purpose create a translation. So let me begin with a few examples using the Elizarov fixator. This gentleman has a varus deformity with some deviation of the axis. So you can see the Elizarov fixator is applied, the hinges are applied at the apex of the deformity. This is an opening wedge performed. You can see his leg is straightening out. And at the end of it, the mechanical axis is passing through about 60%. A triangular shaped bone has regenerated. The deformity is corrected. He has relief of pain. Now let's come to the common Rule 2 corrections. This is a young lady who has got severe bow leg deformity. And you can see she has fixators on her legs, which she tolerates very well. Percutaneous osteotomies are performed. And here you can see the subtle displacement of the distal fragment laterally by at least one cortex. So this is the angulation translation osteotomy, and she has straight limbs, and the X-ray is showing very good correction as well. So make friends with Rule 2, because Rule 2 is where you're going to be doing most of your deformity correction work. And there are two ways of looking at this. Either you try to do it theoretically by placing the hinges accurately at the cora, or you can do it in a workman-like fashion. Understand the concept and use a cheat sheet for the translation. That is, start with the end in sight, as the Taoist says. Start with the end in mind. You know you want to get a translation. So you could set up the assembly with whichever hardware you have, with the Elizaro, with the LRS, or even the newer, later nails and plates, and achieve the lateral translation of the distal fragment. Here is a young pediatrician who has a growth arrest in childhood with a varus deformity of the ankle. And here you can see the Elizaro fixator. He's also got shortening. We have lengthened this tibia and his fibula. You can see how the motors are angled in order to remain perpendicular to the axis of the osteotomy and to make sure that the joint line becomes more or less horizontal. Here he is, he's doing well with no symptoms now, the deformity corrected. For someone who has another very severe juxta-articular deformity, you know that ALDTA is 90 degrees, whereas in this case, it's close to 30 or 40, a lot of valgus. So we perform a very low osteotomy in the tibia. Again, notice the direction of the motor rods over here. So we have the ability to change the direction of the force that we apply based on the hinges, so that we are always perpendicular to the direction of the osteotomy, and we get the desired amount of translation as well as the angular correction, and a little bit of length in this girl. So we translated the distal fragment laterally so that the proximal and the distal fragments could line up. We can use this to perform lengthening as well. It's not only the simple deformities. Take a look at this young lady. What deformity does she have? She has got actually a varus. She has got a recurvatum. She has got internal rotation deformity, which appears as though it's in valgus. So the Elizaro fixator allows us to percutaneously tackle both problems. In all the problems, we can apply the rings mimicking the deformity, perform a percutaneous osteotomy, and gradually correct the deformities. The rule is first start with angulation, okay? First start with length, then with angulation, and then we do the translation, and then the rotation. For all of these, we need to make changes in the fixator montage, which is a little bit of work, but it enables us to do whatever is needed and to make the limb straight and to make the limb lengths equal, as we did in this young lady. Now I come to the concept of the oblique plane deformity. The oblique plane deformity was something that took us a long time to understand. From about 100 years, from the time of Wilhelm Röntgen, we've been taking X-rays only in the AP and the lateral planes. For the first time, we understood the concept of the oblique plane deformity. This young girl from Mumbai has malunited fracture, and this here is not her knee. This is the malunion. There is procurvatum and valgus. So we draw the cross section of the bone in the midst of a ring to help us to graphically understand the deformity and where to place the hinges, okay? And we want to perform a little bit of lengthening. So the opening wedge hinge is placed at the convex cortex. The hinges are placed over here, exactly at the convex cortex. This is the distractor rod after analysis, and the osteotomy helps her to straighten out the limb. Her lengths are equal, and there is no translation at the malunion site. You can have oblique plane along with rotation. This young lady had chronic osteomyelitis. Can you quantify these deformities? It's a varus, it's a recurvatum, it is internal rotation and shortening. So what we do is we start by the rings mimicking the deformity. The rings are placed perpendicular to each fragment so that we first start with recurvatum and varus, and then when we gradually lengthen and correct the angulation and the rings become parallel, that is when we can perform derotation using a derotation assembly to give us limbs that are straight, completely derotated, and free from any deformity in any plane. Sometimes, with the Elizarov fixator, you can correct any deformity. This is a young lad with Blount's disease, fortunately not so common in India, but you can see this very dramatic varus procurvatum internal rotation deformity walking with great amounts of difficulty. Here what we need to perform is an intra-articular osteotomy because you know the medial condyle is depressed and we perform a hemi-plateau elevation so as to make the condyles collinear, fix it with cancellous screws, and an immediate second osteotomy fixed with the Elizarov like so, and we can fine-tune the correction so that we can get the perfect mechanical axis in both the lower limbs, both AP, lateral, axial, and the rotational planes to give him a perfectly straight limb.
This is a mother of 4 at the age of 34 years of age.
So before I start with this, this is now some more applications of the Elizarov. So the second generation has really given us a lot. This is mother of 4 at the age of 33 or 34. She has this uncorrected clubfoot, but she has got a round talar dome. So let me go back to my experience with club feet. And as I promised, this is going to be about personalities as well. So here is Professor Ignacio Ponseti, whom I had the privilege of visiting in the year 2002. He was 89 at that time, and I spent a whole week, a memorable week with him. Here he is interacting with the mother and carefully examining the child, counseling the mother with tenderness and care. And here he is, look at his gentle concentration as he is molding the arch of the foot, if you can watch, and his fingers, the radial aspect of his index finger is giving counter pressure on the neck of the talus. And very gently he's molding behind the heel cord in this, done very gently. If to watch Professor Ponseti was to understand the meaning of the word gentle. And here he is finishing the cast, examining it. And can you believe it? Which one of us trims our casts and takes so much care? He did that. He elevated the art of the plaster cast to a high religion. And I'm so grateful I got to see him. For those of you who haven't heard, Dr. Ponseti was heard remarking on his 80th birthday or 81st, remarking to a friend that I think I've just started giving a very good plaster cast now after so many years. So these great personalities give us a lot of lessons. And look at him. At the end of the cast, the baby is quietly asleep. And here is the great old man sharing a quiet moment with one of the millions of children whom he helped to correct. And it was a wonderful time that I spent with him at the University of Iowa. He took me to several musical concerts. He gave me a deep understanding into the nature of conservative therapy in orthopedic surgery, including the treatment of scoliosis. He did a lot of work on growth plate and achondroplasia, on dislocation of the hip, but he hit the jackpot with clubfoot, and that too after he retired. This is in his home. This is a very young and enthusiastic me with him, treated to a fabulous lunch by his wife, who's an accomplished literature. And so based on my understanding of the Ponseti, I could create the perfect amalgam of the Ponseti software with the Elizarov hardware. And you can see over here in the animation, we first supinate the forefoot by using the force couple, like driving a steering wheel, because the forefoot supination matches that of the hindfoot supination. And then we abduct the forefoot as we do in the cast by dropping off these motors from the tibial ring. Notice there is a dropped wire into the talus. All this time, the hindfoot is kept free because Dr. Ponseti tells us, do not touch the calcaneum in the beginning. And then we can differentially correct the inversion as well as the equinus. The animation is not 100% correct, but you get the idea that the motors of the hindfoot are angled and they change to always remain perpendicular to the moment arm. You can see the assembly here. So the Elizarov allows us to do a lot of things, give very selective forces, apply the pressures, and can allow you to do anything you want if you have the patience. This is another view of how the Elizarov technique was married to the Ponseti. And I was invited to lecture on this at the Baltimore Limb Deformity course in 2003, 4, and 5. So we first supinate the forefoot. You can see there is a dropped wire in the talus. Then from above, you see how the forefoot is being abducted. As the forefoot abducts, the calcaneus also rotates from underneath the talus until it's the AP talocalcaneal angle is 20 degrees. And then it is free to come, out of the equinus, come out of the inversion with the help of the hindfoot motors. The hindfoot motors always remain perpendicular to the movement arm, as I will show you in another animation immediately. If you don't do that with the fixator, or if the fixator that you use does not have the capability of selective control, what can happen? So let's take a look at what's the perfect method. This is using trigonometry. The center of rotation of the talus is at the lateral process. The line joining this and the tuberosity where the force is applied is the moment arm. If you apply a force exactly at right angles, it resolves into vectors F1 and F2. Here only the vector F2 acts because it is F into cosine of theta, which is 0. And therefore you get all the force being translated along the axis, along the center of rotation. So the key to remember is to always be perpendicular to the moment arm. From the center of rotation to the application of force is the moment arm. So your force must be applied at right angles, meaning you can't keep your stud straight. You have to be perpendicular, okay? And this is when you're not using hinges. Because of the deformity, you cannot accurately place the hinges. If you don't do this, and if perchance you apply the forces in a slightly different manner, what will happen? This is the moment arm. And instead of the perpendicular, if you apply the forces, I hope this is the correct animation. It probably is not. Let's see if it's this one. If the forces are applied at an angle theta away from the perpendicular, then this is the angle theta, which is not perfect. Then the forces resolve into F2, which is a smaller force, and F1, which is a yet smaller force. And then it either translates the distal fragment anteriorly or crushes the cartilage or over distracts the ankle joint, because it resolves into two vectors instead of resolving only in the vector that needs to do the job. And when we understand these concepts, when we marry the principles of the Ponseti very faithfully with the Elizarov, we can get very accurate corrections. And you can see she even has dorsiflexion, some dorsiflexion, and she can squat. So this has been one of the great joys of working with the Elizarov fixator. It is indeed labor intensive, but there are so many things you can do with it. Now, I'd like to briefly point out a few more great uses of the Elizarov. This is avascular necrosis of the head of the femur. This is a case done in 1993. Young lad after fracture neck femur. You can see the trochanter is overriding over here, the changes of AVN. So in those days, we applied the Elizarov fixator, did two osteotomies. This is medial displacement of the distal fragment at the subtrochanteric osteotomy. So that allows forces around the hip to be reduced. It reduces the forces on the hip. And then a distal lengthening in the same side with a little lateral translation of the distal fragment with lengthening and his axis lined up. And here is immediately after surgery, there's no Trendelenburg lurch, it has been corrected. And this is not just 20, it's now 24, 25 years following surgery. He doesn't have a Trendelenburg lurch. He can squat, he can sit down. His axis is perfect. His knee, the axis runs through the center of all the joints. And though the X-ray is not very pretty, he's very functional with very few restrictions to his activity, despite being in Mumbai working in a multinational corporation. Sometimes we can, use this Elizarov hip reconstruction to perform in an untreated dislocation of the hip. In this young lady, we can perform the two osteotomies, the subtrochanteric valgus and the D valgus osteotomy, to help prevent their lurch when you can't get the hip down at this stage, because it's very risky for the sciatic and the femoral nerves. And she can now walk without a lurch. The same thing is repeated on the other side. And now instead of trying to do the impossible, like a total hip replacement at the age of 14, you can give these children a lot of years. I have people who were operated 25 years ago who can squat, who are married, who have children, who can perform all their activities with the help of the Elizarov hip reconstruction. Do I respect total hip replacement as the operation of the 20th century. You know, this epithet was given to the THR surgery in the journal Lancet and the New England Journal of Medicine. It is indeed a wonderful surgery. When done at the right age, by the right surgeon, for the right indication, it's fabulous. There's no words to describe what a great operation it is. But for a lot of young adults, the Elizarov hip reconstruction, even though the bone looks zigzag now, it's going to remodel quite a bit. And which is why we do this only at the age of 14 years, you know, or after the trochanteric epiphysis fuses. And it gives a pelvic support and it allows them to even sit on the floor and do all their activities. And if it all required 20, 30 years down the line, and it hasn't happened, I have at least 10 people who are now more than 20 years follow-up, who are carrying on with this surgery with very few limitations. Now, having given you an exposure to some of the more orthopedic indications, the classic deformity indications, I would now like to share with you some of my passion about some of the really interesting things that we can do with the Elizarov fixator. This is second generation still, okay? And we can do such a lot. Now, we are coming to achondroplastic dwarfism. This young girl is an achondroplastic dwarf. She came to us from the city of Pune more than 20 years ago. You know, in achondroplasia, it's a short-limbed dwarfism. The height of the trunk is normal. So if the child is sitting in a classroom, nobody can make out that she's a dwarf. The moment she stands, you know, or he stands, obviously apparent that very short. It's a short-limbed dwarfism. You know, the upper limbs are short. They don't reach till the middle of the thighs. They only reach to the top of the trochanters like so. And there's a varus deformity, and they have problems in the spine and in the knees, and they develop osteoarthritis. So most surgeons concentrated only on deformity correction, but with the Elizarov, you can not only correct the deformity, but you can also perform lengthening. Here is bilateral double level tibial lengthening, after which she gained 11 centimeters, after which her lateral popliteal nerve is intact and fully functioning. And then we performed humeral lengthening. You can see where the humeri reach. That's only till the top of the trochanters. And as a result of that, they have to bend down to be able to reach for toilet to the perineum, and they develop a gibbous. And so we need to restore their bodily proportions with humeral lengthening, which is carried out fairly, is not that troublesome as you may imagine. And here she's with restored proportions, and finally close to skeletal maturity, a second cross lengthening. And here she was with a mom when she was all of 20, with a total of 33 centimeters of length gain. And she got an opportunity to become 4'10", which is short normal in India. And she found the love of her life. She married. She has a wonderful Bonnie baby daughter, and she leads a normal life. Something that may not be possible for a lot of achondroplastic children. You know, we presented our work in IOACon in Indore, and our poster won the gold medal. And we have treated many children with achondroplasia. And I would like to tell the parents that if you want your child not to suffer from the complexes of a society which is unkind to those who are differently abled, if you want to consider, you should start the treatment early so that you can get a lot of, you know, possibility of a lot of lengthening. I don't do all the 4 limb segments at one time as they do in the US, because our support systems in India are not that good. We do it in phases, but it's not a very painful treatment if you know how to prevent complications, and you can give a lot of length. So based on my work, I was privileged to be invited to this meeting in Milan in Italy in 2012. Today, Milan is all in the wrong news, but Milan has always been a favorite city of mine. I've visited it many times in these last 30 years. This is the ISAC Italy, the first organization in the world who support dwarfs. It's a support system for dwarfism for the parents, and they called the 12 surgeons in the world who do most surgeries. Here is Professor Jean-Marc Guichet, who's the inventor of the Albizia nail. He started working on his self-lengthening nail as a medical student, not even as an orthopedic resident, mind you. He started working as a medical student on this project. And this is Professor, I think, Villarrubias from Spain, and his other team members from Spain who do a lot of lengthening. And they taught us the value of anterior soft tissue releases to prevent deformities. This is Professor Valentin Novikov, the chief of the lengthening department in the Kurgan Institute. This is Professor Kamal Hosni, the great surgeon from Egypt. And these are surgeons from Spain and Italy. And here, of course, is Dr. Dror Paley, who was along with me. And here I am, way behind in this group of mostly European surgeons. It's been a privilege of my life to be able to help these achondroplastic dwarfs to increase their height. And this is something that we can really make a dramatic change if done judiciously and well. So now this brings us to another very interesting application of the second generation of Ilizarov techniques. This is the story of a young Japanese American who approached me in 1999. He said, by email, I need to get my height increased. So I replied, I only treat achondroplastic dwarfs. I do not treat young people. I do not believe you should have this surgery. So he writes back saying, if you don't do it, I'm going to go to Delhi or some other place. So I said, no, but why should I do it? Then he writes back to me. This goes back and forth several times. He writes back to me saying, you don't know what it is to be 5'3" in America when your mother is 5'9" and your younger brother is 6'4". You don't know what it means. Why don't you consider my case on an individual basis? And I did it. I was reluctant, but I realized because we had performed lengthenings of the tibia in short femora sometimes, in infected femora, and I knew the safe limit at that time, having deeply worked with the Ilizarov. So I knew it was 15%. So we lengthened his femur and his tibia. He stayed with us for a while. He was a very good patient. And, he got all of his desired 11.5 centimeters of length. And here he's removing the fixator with his own hands. Take heart, those of you who think Ilizarov is torture. It is not. You have to learn how to control the fixator. This is him while he's about to go back home. Because he was only about 19, he said, I'll tell my parents I just grew in this period as I was traveling and I sustained this fracture. So here he is with my technician before and after. This is the story. So I do very selectively for these young people. Now the story about who this gentleman is also very interesting. It so happens that he was the scion of the family that owns this particular brand. And I did not know about it for quite some time. Anyway, that's about personalities. So having shown you what can be done with limb lengthening, which is like a correction of an axial deformity, I would like to now focus a little bit on some congenital anomalies and some congenital deformities. Just a couple of days back, we had a fantastic webinar with Dror Paley on the really complex congenital hip anomalies. But I'd like to show you about, this is congenital femoral deficiency type 1A. With a hypoplastic femur, you see there's no notch here, and you can see the amount of shortening. We start by performing a femoral lengthening, but before that, we perform preparatory surgeries in soft tissue releases, very often a Degas osteotomy so that the hip doesn't subluxate. And you can see this very crucial need for the knee range of motion so that he gets this entire range of motion after lengthening, and the need for this intramedullary rod to prevent refractures. These are all crucial lessons that we learned years and years and years ago. And then this young lad had a second lengthening in the tibia. So if we perform modest and moderate amount of lengthenings carried out over a period of time, along with judicious soft tissue releases, we can give a good result without ending up in complications. So the key in congenital anomalies is number 1, preparation of the soft tissues. Number 2 is starting early. Number 3, keeping your goals modest. And this is where we do not like Shah Rukh Khan. So he's India's heartthrob. He got it all wrong for lengthening surgeons when he said, "Ye dil mange more." If you allow your patients to fall prey to this very, very erroneous notion that they should get a lot of length in one time, then they're going to end up in trouble. It's only achondroplastic dwarfs who can get a lot of length in one go. And there's a very interesting technical and genetic reason for it. All other people, including cosmetic lengthening, and the worst of all is congenital anomalies, is they get very little length. It's about 15% of the segment beyond which you start running into difficulties. And a lot of literature has come on this subject. And here's congenital pseudoarthrosis of the tibia in somebody who's 14 years of age, a very distal pseudoarthrosis. And I've treated more than 64 of these over the last 30 years. And this is the trusted Elizarov fixator. This is an intramedullary nail, a very high jiggly saw corticotomy, making sure there's no unhealthy bone here. There is gentle resection, invagination of the bone ends, bone grafting, periosteal grafting, sustained and continuous compression at the pseudoarthrosis site, as well as lengthening to improve the vascularity, as well as, reduce the leg length discrepancy. And here she is with a united limb. We, of course, brace them for some time. I am, of course, aware of the latest work by Dror in which he does the 4-in-1 technique, which started with Professor In-Ho Choi in Korea, in which you try to, fuse the tibia and the fibula, create a 4-in-1 construct. We've been doing it for the last couple of years, but I just want to show you, even without that, it is possible. Even without the use of BMP and the exhaustive bone grafts from the entire iliac crest, we can achieve union, as we have done in more than 85% of the cases, with a refracture rate which does not exceed 20%. This is a very young child, again, with congenital pseudoarthrosis. You see that very dramatic deformity at the lower end, like so. Okay, you can't even see it in the AP, and we can do the same fixator. And you can see even in little children, they can tolerate the fixator very well. After the second day, they stop crying, they start playing with the fixator. You can do the lengthening, completely correct the deformity. Always a foot frame is used to enhance the fixation of a short distal fragment. Lengthening is not compulsory, but it helps. But the important thing is to give sustained compression, especially these were all done several years ago. This child was treated 10 years ago. So regardless of the age of the child, we can treat the congenital pseudoarthrosis, treat the apex anterolateral bowing deformity with the CPT, and get them to heal very nicely, like so. I will end this part of my presentation by talking about what seems to be an unintuitive way of doing things and the role of shortening and soft tissue reconstruction in several congenital anomalies. Here is a young engineering student who has a congenital dislocation of the patella. You can see over here, and there is a posterolateral rotatory subluxation of the tibia, as can be apparent. The surgeon started by performing osteotomies for lengthening because she was already short, not realizing the extent of the deformity. Notice the subluxation. And what these people need is a lot of things, but limb shortening is an integral part of it. So this is a big soft tissue release. These are 2 strips of the fascia lata. This is a plate after the limb shortening has been performed. And we have performed the reverse Macintosh procedure on the medial side and the Macintosh on the lateral side to give stability to the knee, and have, using the Langenskiol procedure, put the patella back in the center of the femoral condyles by recreating the retinacula and by overlapping the medial side. And here you can see that now the limb is aligned, the subluxation is reduced, and she also has a range of motion which will gradually increase. There are several other indications where shortening can help. We are all aware of, developmental dysplasia of the hip, in which we perform femoral shortening and a derotation osteotomy to reduce the soft tissue tension. The same principle applies here. In this amputee girl who has never walked for a long time, were we to apply the Elizarov and do a gradual correction, she'll not be able to walk for a very long time. So instead of that, we perform a dramatic amount of shortening and translate the distal fragment laterally using rule 2 of deformity correction. And you can see now the axis from the center of the femoral head to the center of the ankle and the center of the knee all completely line up, but it needs a dramatic amount of translation. The further away you are from the site of the deformity, the more translation you will get. But it doesn't matter because it lines up. And with the fixator, you can get them to heal. She's walking, and she was walking immediately after surgery, something which would not have been possible, and she could have even developed bed sores. So I will end this session with this very interesting case of a young lady. But before that, many of you are aware of the cartoonist Morparia, who has daily cartoons in a daily in Mumbai. I had the privilege of being Hemant Morparia's first editor of Bosu Mag in KM Hospital. Now he's an accomplished and very successful cartoonist. And when he knew that I have come back and learned limb lengthening surgery, this is the cartoon he sent me. This was sent to me by him 28 years ago. This is specialties alterations. I I had a loud laugh, but I said, come on, Moru, you can't be serious. But little was I to know that in the year 2000, I was going to face this problem myself. This is a young lady who came to us from England. She's had lengthening in the left lower limb as part of the first part of the surgery for cosmetic limb lengthening because she wanted to become an air hostess. And what happened was everything went terribly wrong. She developed a valgus and a procurvatum deformity. And here you can see we have taken the full length X-rays, AP and lateral, and then resolved the deformity with this oblique plane analysis. So this is the true deformity in an oblique plane. And at right angles to that, there's no deformity at all. What this young lady told me was that I need you to make these limbs completely straight, both the femur and the tibia, and yet make sure that combined, they are only 12 millimeters longer than the opposite side. Now, it was a tedious calculation. She was lengthened totally 36 millimeters, but when we take the X-ray, she's now only about 8 or 9 millimeters long because of the deformity. So we have to calculate very accurately, and we can do that. So the way we did it was we needed to perform a closing wedge with shortening, with correction of the deformity. So we determine the radius over here. We know the formula from geometries. The chord length is 2 pi r alpha divided by 360. Here r, the radius, is the distance from the structure which is at risk, which is the lateral popliteal nerve. So r is different for the concave and r is different for the convex cortices. So you resect a wedge of bone like this. And how do you do the calculation? The r here is the distance from lateral popliteal to this cortex, and alpha is the amount of angular correction you need divided by 57. This equation, and you get a very accurate correction. So you can do this in cerebral palsy to determine how much shortening you need. You can for correcting fixed flexion deformity, and there are many uses in orthopedics. And this is exactly what we did. We shortened her tibia, made it completely straight, took a scanogram to make sure it was exactly 6 millimeters longer. Okay, so this is before and this is after surgery. And we did the same kind of planning for the femur. This is valgus and procurvatum. Here you can see this is the graphical method of planning for oblique plane deformities. This is her outline of the foot looking down from above. This is the outline of the femur. And this is the analyzing the deformity tells us where to place the hinges. And we corrected her femur and by resecting a wedge, and she became completely straight like so. And at the end, went away happily with 12 millimeters of lengthening done on the opposite side. So I'd like to end this session by expressing my gratitude to all the great people from whom I learned. This is Dr. Dror Paley, who's been a teacher to all of us. I have learned so much over the years with the Elizarov techniques and the newer modalities that he has used. So this talk is also about gratitude to all the great teachers we have. And this ends the talk on this 2G, that's the second generation. Even though this was long and exhaustive, this is important because I want to convey to the young friends we can do a lot with only the Elizarov method. So I'll stop here, Shiva.
Yeah, I will take some few questions. You can stop sharing for a minute. Share screen, yeah. We have one of the interesting question from Major Rajiv Kaul from Pune. When you came back to India after your initial training and uttered the word Ilidro before your colleagues and patients, did you face any resistance from the system? And if so, how did you tackle it?
Yeah, it's a very interesting question. It takes me back many years. The first question is, what? You're going to lengthen bones and you're not going to do bone grafting? Arey, iska jara examine this guy's head, yaar. Stuff like that. And what are you doing in Akola? Well, you will finish before you start if you are in Akola. I hear so many things. But like one of my young fellows, tells me, and I have the privilege of now training more than 90 young orthopedic surgeons in 6-month fellowships. He says it's easier to convince your patients of the Elizarov than other orthopedic surgeons. So There are many stories about how difficult it is to convince people. But the truth of the matter is, the Elizarov is like a comprehensive system. It's like Unix in computer parlance. You can do everything with it, but you just need to delve deep into it. And I had the ability to create the apparatus. So I understood the apparatus in great detail. You have to create a team for the post-operative care. You can't do it alone. It's not a one-man's job. So to make it succeed, you have to be able to show the patient that you're going to be pain-free. You have to keep him pain-free. And the way to do it is make sure that the fixator is stable and that the fixator is taken care of by your team. And I did it myself for the first several years. Now we have a team who takes care of the apparatus. So when the patients are free from pain and they're walking about, going about happily in society, and that's when everybody sees that, hey, this patient is free from pain. And his leg was very crooked and now it's long. So you have to stick to it. There are, of course, very many newer modifications which we are coming to. But yes, people do have reservations about the fixator. And one needs to ensure that one does it properly. That's what Professor Elizarov said. If you do it right, you have no complications. Yes. So it sounds like a tautology, but it's very true.
Yes. So you have worked with Rourkela and learned a lot of things. But when you came back to India, you hardly had anything. Did you think that you made a mistake of going to this subject and you should have done something else, fellowship in rather something else?
Yeah, so this is a very interesting, all these questions are close to my heart. It was very difficult at times. There were lots of ups and downs because everything is a fashion. And, a couple of years after I started Elizarov, everybody started doing Elizarov. So I was working in Mumbai for some time also, partly because I was going to KM Hospital Library to reference till I got my first CD-ROM in 1993, the JBJ CD-ROM. And I was working in Mumbai part of the time. And people are saying, ki tu aar Bombay kai ko aata hai? Sab log Elizarov kar raha hai. Fir koi yahan kuch nahi milega. So it is true that everybody swung towards Elizarov, then everybody gave it up because nobody wanted to understand the nuances. The biggest difference of the Elizarov and the other methods of orthopedics is that the Elizarov is a process. And, whether it's internal fixation or arthroscopy or joint replacement or spine surgery, it's a do it and forget it procedure. Either you succeed or you fail. With the Elizarov, you can make it succeed in the post-operative phase. So yes, it can be difficult and one has to stick to it. If one likes one's subject, success and failure is less important.
Yes. Elizarov requires lots of patience and lots of mathematical calculation. How difficult it is to learn, and whether your love for trigonometry has helped you in making these things easy for you, and it is really still difficult for all of us.
Yes, the answer to this question is coming in the next talk. Okay. Everybody doesn't have to break their heads with trigonometry. I just developed a love for trigonometry after reading about it, after trying to solve complex problems. It is not always necessary. There are lots of shortcuts. I have several talks, which I'm not giving today, on what's known as the cheat sheets for understanding translations. There is a theoretical way of doing things and there is a practical way of doing things. So you need not always use trigonometry. But to tell you very truthfully, the trigonometry formulas are very simple. They're high school geometry, okay? 2 pi r alpha divided by 360. Come on, you learned this when you were 15 years of age. R alpha divided by 57 cannot be difficult. Using a scale, a goniometer, these are not difficult. And now we have so many software for planning. And now we have so many new advances, okay? I'm coming to it. The third generation has solved this problem.
Yes, I learned Ponseti technique from you. I came to your workshop in Akola in 2003 or 2004. I don't remember when Pirani had come. Yeah. Really, it has helped a great extent. We have missed you. Milind, we have missed you. Ashok, you have to re-enter. Yeah. So actually, while that was the time when there was no Google or anything, internet was just the broadband we were using from the landline. So there was no Google or no Android phone. So while coming from Sholapur to Akola, In the night, middle of the night, we lost the road, and almost it took more than 18 hours to reach. We started at 2 in the afternoon from Sholapur, but by the time we reached Akola, it was almost 6 or 7 in the morning. So how did you got the involvement apart from just going to Ponseti himself, and how did you develop this interest in club fit?
Yeah, so Shiva, I told you, I worked in the Children's Orthopedic Hospital in Mumbai, Haji Ali, 1986. And every day we had at least 30 to 50 children on whom Ponseti casting was done, and then surgeries were done.
Okay.
And over there itself, I saw a randomized controlled trial going on. Dr. N.M. Shah did only Attenborough posterior soft tissue release, and Dr. P.H. Vora did only posteromedial soft tissue releases. Dr. P.H. Vora was very nice. He was good. But over there, then and then, I understood that there is no need to do any single posteromedial soft tissue release. It was a very deep learning of club feet. I must have seen hundreds, if not thousands, in the 6 months that I spent there. Yeah. And even with my Elizarov, I was doing casting and Attenborough soft tissue releases before I met Dr. Ponseti. I must have done at least 800 posterior soft tissue releases. I always have been treating club feet. It's a subject very dear to my heart, along with polio.
Yes.
So I went to Dr. Ponseti, and you know, Shiva, my name is Milind, which in a certain, this thing means it's a Brahmar. A Brahmar is a creature that goes and takes nectar from various sources.
Correct.
So I always wanted to go to the source of learning. I always wanted to go to the source person. I didn't want to get second-hand knowledge. So I was very lucky. I have been very lucky. I've also been to the father of microsurgery. That's Professor Harry Bunke in San Francisco. I've been to Dr. Ponseti. I have been to, I'll come to it, Charlie Taylor. I've been to Professor Koshino in Japan. So one of the great joys of my life is interacting with very great surgeons and innovators themselves.
Yes. Okay. One of the question I received was in this X-ray, the mechanical axis, whether you're drawn along the femur.
I've drawn it wrong in this X-ray.
Yeah, that's
it's through the center of the femoral head, and it's you can see it's lateral everywhere. I had only 48 hours notice to gather this very large talk. So
okay, because the people are still
no pain in the knee joint.
Yeah, that's correct. No, just to inform you that the people are really watching you with
with the hawk's eye.
Yes, okay. That's correct. So you said you love to marry a Ponseti with the Elizaro and use the technique. Is it true that you don't use any calcaneal wires when you're doing the correction?
No, not at all. Not at all. See, what we do is the Ponseti's term, you read the Ponseti's book, the club foot.
Yeah.
He says, do not touch the calcaneum while the abduction is going on, meaning allow the calcaneus to rotate. So we place the hindfoot ring with 2 wires or thin half pins, but do not connect it to the tibial rings or the forefoot ring. So as the forefoot is being abducted, the calcaneal ring, which is free, also rotates. And then when the abduction is corrected, then you attach the connections to correct the hindfoot equines.
Yes. What the take on Jess versus your Elizaro fixator for the club foot, because Jess has a calcaneal wires.
I understand the question. I understand the question. Now I know Jess is very popular. Professor Joshi was a great friend of mine. I was a great admirer.
Because I do by Jess.
Yes. I know everybody does by Jess. It's very simple to apply, and the Jess works in a different way. It distracts everything apart and makes everything supple. Okay. Yes. Now we are trying to do kinesiological correction with the Elizaro. We are trying to follow the principles of the Ponseti method, manipulating the fragments exactly in the way it's done in the Ponseti. To each his own. Yeah. I have very good results with the Elizaro. It's easy for me to do it with the Elizaro. But if you're happy with the Jess, please continue to do so. I have no quarrel with it.
Okay, you can start sharing your screen. We'll come back to you after your next presentation.
Yes, so we're going to...
Time is not a restriction. You can continue. No problem. The way it is going, it's really fantastic.
I'm going to take a while to load my next presentation, please. This is,
there is, meanwhile, you can answer a question. Dr. Nikhil Agarwal asks, Have
Yeah.
you ever thought of applying distraction osteogenesis and neovascularization principle in solving AVN femoral head with Elizaro?
Wow, that's a really nice question. Um, no, the short answer is no. Let me point out to you that there are certain very practical limitations that we have on the Elizarov method. And I'll tell you what the role of the Elizarov can be in avascular necrosis of the femoral head. Now, I want to point out to you, gentlemen, that do you know what the latest method of treatment for acute avascular necrosis is in Cellspital Bern, in Ganz's unit, in the unit that was run by Maurice Müller, the great Maurice Müller, and then Reinhold Ganz, and now Klaus Siebenrock? What they're doing for acute AVN, you'll be surprised. You know what they're doing? They're doing surgical dislocation of the hip. They're opening up the hip joint. They're removing the damaged cartilage. They're first giving traction MRI, seeing which part of the cartilage is delaminated. They do surgical dislocation, preserve the vascularity, remove the cartilage, remove the dead bone, put in a bone graft, put in a membrane, put the hip back and perform an acute varus osteotomy. Okay? They're performing an acute varus osteotomy. They're not bothered because they can correct the osteotomy at the time of whenever total hip is needed. So similarly, I have done in several patients who come with burnt out AVN, we can perform the subtrochanteric osteotomy. Medial displacement, the varus can turn the lesion away from the weight bearing area. The medial displacement can reduce the forces on the hip. I have also performed the Sugioka osteotomy after learning how to do surgical dislocation. So, but directly just to improve the vascularity, unfortunately, nothing as dramatic as that. I'm so sorry. So let's now begin. Am I with you, Shiva? How can I share the screen?
There is a green button down. Press on that and you open your presentation first. Then press on the green button down, share screen.
Okay, so now let's come to 3G. Let's come to
Yes.
3G speeds. Okay, let's come to the third generation of deformity correction. And I have seen all of these at very close quarters. So let's come to the third generation. So what were the problems with 2G? This is exactly the question that you asked me. You love trigonometry, you like to do calculations. What about us? So the problem is for most people to understand and analyze the oblique plane deformity and the difficulties that come along with that. And that's very much understandable. We are orthopedic surgeons. We like to do things with our hands. We don't want, we don't want to be analysis, paralysis. We like to do things. We are dynamic, go-getting people. But the other problem with the Elizarov, with the 2G, the very big problem with the Elizarov, and the reason why most people discontinue working with the Elizarov fixator is that it is intensive, laborious work to make changes in the postoperative period. It is not a labor-saving device. You need to work on the device. Suppose you have corrected the angulation and the rings have become parallel. Then you have to set up a rotation assembly or you have to set up a translation assembly. It's a lot of work. So unless you learn how to train your team, your youngsters, your colleagues, the young folks around you who can do justice, who've got a good pair of hands, then you will be in trouble. You will get tired and bored and frustrated. And the biggest problem, of course, is this analysis. Finding the oblique plane is either by the graphic method, which I tried to show you, or by the trigonometric formula arc tan of tan lateral upon tan AP. But pretty honestly, between you and me, this is not difficult. You can do it on your calculator, the inverse tan of the tan lateral up divided by tan AP. Come on, it's not difficult. And the magnitude of the deformity, because when you reach more than 45 degrees, the graphical method becomes inaccurate. So, but the trigonometric formula is always accurate. Mathematics is always accurate. So the oblique, the magnitude of the deformity is given by arc tan of the under root of tan square AP plus tan square lateral. It's not really difficult, but still, a lot of people say, "Ala, ye to bahut magaj mari hai. We don't like this." And that's what happened. That was one of the big things that happened. People didn't know how to take care of either the analysis or the postoperative care of the Elizarov. And to the rescue of the orthopedic surgeon, came the Taylor's spatial frame. This is the first 6-axis correction device, or what's now known as a hexapod. This is a 6-axis correction with software control. And it uses the same principle as the aircraft simulator. You know, if you've been to Australia or some other place, in one of these fun places where you sit in a simulator, you pay $150 to simulate flying a plane, and it goes, you really get the feel it goes up and down. So there are 6 struts actually underneath the simulator, which are moving them, simulating how you're moving. So this is based on Euler's transforms. And this was invented by Charlie Taylor, J. Charles Taylor, Campbell Clinic, Memphis, USA. Okay, this is Charlie Taylor and me in the year 2001. Now, Charlie Taylor is a professor of Campbell Clinic. If you have Campbell's textbook of orthopedics, the 7th and the 8th edition, you will see that the chapter on fractures is written by Charlie Taylor himself, okay? He's a great trauma surgeon. And like all intelligent people, he was always trying to figure out how to do things better. So the Campbell Clinic is probably the top 3 busiest orthopedic centers in the US, after some places in New York and a couple of other places. Campbell Clinic has a huge workload of compound trauma coming in the middle of the night. And what he saw was that his residents were performing external fixation in the middle of the night for compound fractures with debridement, and they were having a hard time, you know, getting the fracture lined up. And it was also tiring to get up at 4 in the morning and to do this. So he wanted to dissociate fixation from the accurate reduction of the fracture. So he started thinking. Now you see, he has a degree in mathematics, and his brother is a professor of mathematics, also in Memphis. So they designed the Taylor spatial frame. It's a fantastic piece of software engineering of matrix mathematics. And I had the privilege of being in Memphis at a course run by Charlie Taylor himself. This is Charlie Taylor. This is Rob Rosbrook, now in hospital for special surgery. This is Jor. This is Dr. Charles Binsky. This is James. This is John Herzenberg. And these are gentlemen from Israel. And here is me, the darky in the lot as usual. But I had a great time. I learned such a lot because I could interact with Charlie and really get to know the thing firsthand. And so now the great advantage of the Taylor spatial frame is that you don't have to analyze complex. You can just measure the deformity on the X-ray. So over here on this X-ray, you see this procurvatum deformity in the femur. So you write, this is 80 degrees of procurvatum. And in the tibia, this is about 40 degrees of recurvatum. That's all you need to write. And you need to write how much rotation is there in the software. Apply the fixator like the Elizarov. It's exactly like the Elizarov with additional tabs. And instead of 4 struts, it uses 6. And do the same percutaneous osteotomy. And then the software will tell you how to turn the struts so that you get a very accurate correction. You have to dial in the translations. And of course, when things go wrong, you have to have the ability, to convert it to the Elizarov system. So here is this, here is the earlier version of the software. This gentleman has a malunion with very poor soft tissues. You can't go down and do a nailing or a plating. Really tough soft tissues. This is anterior, procurvatum, distal, posterior translation, medial translation, shortening, internal rotation. So this is the software in which you fill the data. Here is 18 degrees of varus, 15 degrees of, AP view translation. I have written, translation like this, and you enter all the parameters in the software, and it tells you most of you are exposed to the hexapods. The Taylor spatial frame, I think, is the most elegant. It was the first, and according to me, is still the best, is the easiest to use. It's now available in India for a reasonable price. You can reuse some of the struts. They will work for 3 or 4 occasions. The rings are not expensive. The struts are. The software is free to use on the web, and you can reuse it a couple of times. Even US FDA allows the external fixation components which are outside to be reused. So here he is with full correction of his deformities, removing the fixator himself with absolute correction, millimeter to millimeter, degree to degree. And you don't have to do magajmari. You don't have to change the montage of the Elizarov from angulation to translation to rotation. You feed in the parameters in the bone. And if you get the parameters perfect, you're going to get a perfect result every time. So for example, here is this young lad who has this grotesque deformity in the lower tibia. This is varus. This is recurvatum. This is dramatic anterior translation of the distal fragment, as well as internal rotation, as well as shortening. So this is the opening, page of the software, which tells what is the input we have given. This is 20 degrees of varus. We have put in 8 degrees medial translation. We want it because we want it to move the other way. Now you decide whether the reference is distal or proximal. And that determines everything. For the short fragments, say in the lower end of the radius and in the lower end of the tibia, you always use a distal reference. And in the upper end of the tibia, upper mid shaft of the femur, mid shaft of the tibia, and mid shaft of the humerus, you will use a proximal reference. So you're giving an opposite command. So here I've written 8 millimeters of medial translation. Now, because it's distal, meaning that the proximal fragment has moved medially and we want proximal fragment to move. So you have to be aware of these nuances. It needs a little bit of thinking, but you measure your x-rays, okay, like so, you give the commands, you perform the osteotomy, and at the end of the first stage, when I have reached this level, now I need to redo it. All I have to do is go back to the software and give it the command that a residual deformity remains, and I want to correct some more translation. And at the end of this phase, you can see how much translation is here. I have achieved the desired translation. And all this translated bone is going to completely remodel. It's not going to matter at all. So you can perform the residual corrections with the help of the software. You don't necessarily have to change the struts. It takes away the pain of the calculations. It takes away the pain of the residual changes that you need to make. Now, and it's really very useful in the small fragments in the lower end of the radius, lower end of the tibia. This is a gentleman who's a software engineer working in Bangalore in one of the really famous companies. This is this dramatic deformity. There's a very bad quality of soft tissues here at the wrist, which is completely dorsiflexed and radially deviated. The radius is angulated, and he's all of 26. So how do we do this? To really get accuracy, that's where the Taylor spatial frame comes in. So we put in the Taylor spatial frame to the radius, and the forearm, radius and ulna. We used fixation of the hand, and initially we distracted the soft tissues apart to correct the deformity of the wrist. And then we performed the osteotomy in the radius at the lower end. So here you can see I've entered the parameters. Here the reference is proximal. I've entered 43 degrees of apex radial angulation, 3 millimeters of ulnar translation, 10 degrees of apex dorsal angulation, 4 millimeters of, 4 millimeters of Palmer translation, and he's only 6 millimeters short after doing a lot of calculations. So you need to do some calculations, enter it into the software. The software recreates the image. And the most crucial part is this one, the frame offset. That is, the frame needs to understand this, where in relation to the center of the frame is a relevant point on the bone. So that's orienting the software. So this is the crucial part. The measurement that you take of that point of the bone, which is usually at the level of the osteotomy, is conveyed to the software. So now here we are radial to the origin, 2 millimeters and 8 millimeters dorsal to the origin, but 176 millimeters proximal to the origin. That's the center of the ring. Once this thing is set up, you get the frame parameters, and it shows you how the ring is actually supposed to be looking and how it will look at the end of correction. So here he is at the end of the soft tissue distraction. His osteotomy has just been done. And here you can see he's completely corrected. The deformity is corrected. The contracture is gone, and he's got a straight limb for the first time. Now the Ilizarov with this will be so very difficult. The monolateral fixator will be so very difficult because you have to correct the angulation, the rotation. In both the planes you have to correct. So the TSF really comes, it shines in cases like these. Also, the Taylor spatial frame is very crucial when you want to treat VIPs. This is a professor and head of the Department of Medicine. He has had a malunited fracture. He started developing pain from the varus, like so, a lot of varus deformity. You can see the internal rotation. You can see the shortening as well. So, I'm sorry, I think I've just done something. Yeah. So here he is with the Taylor spatial frame. We feed in the parameters for the varus deformity, for the amount of translation that we need to get the axis. You can see here at the beginning and at the end. So we feed in the amount of translation that you need, about 7 to 8 millimeters of the distal fragment, and the 19 or 20 millimeters of length that you need. And you don't have to change the montage. That's the beauty of it. They get a printed out, program, and they can do it themselves. They can send you an X-ray and say that the leg is still looking short, and you can modify the program and send it to them by email. And they'll get a very good correction like so. You can see his axis is now perfect at 60%, a perfect mechanical axis. He's in perfect health, you can see, and is completely free from pain. And so when it's a really important patient, it'll do wonders. And then again, come to some really complicated deformities. This is a ulnar club hand, and the ulna is short and it is deformed, and the radius is out of the joint. You can see the tip of the radius is over here. This is a complex deformity, and the TSF can really help. So here's the TSF on his hand. There is, on the forearm. We've also fixed his, it's a 3-ring construct. We've performed an osteotomy of the ulna. Okay, you have to remember that the anatomical position is in supination. So you have to remember while giving orders to the software. And first we have fixed the radius, but we have kept it free here. So as the ulna distracts, the radius comes distally. And then we are going to translate the ulna so that the radial head shifts, which is what we have done with a minor change in the program. You can see at the end of the lengthening, some shift is occurring. It is still lateral, it is still anterior. The shift is still occurring. And here he is at the end of it. The radial head has come into the socket. His forearm lengths are equal, and his radius and ulna are as normal as they can possibly be at this stage. And since we are doing it gradually, there's no need to do a Bell-Torres procedure or something. He was very lucky because his radial head, even though he's about 12 or 14 years of age, has not become large. Because beyond the age of 8 years, the radial head can enlarge and it need not go inside. With the Elizarov to perform all these manipulations is difficult. With the TSF is not so difficult at all. So many such examples are there, when the patient demands accuracy. And this is another facet that today, our patients are very educated. They feel they deserve something modern. So we give them the Taylor spatial frame. There are many instances where the bone is very sclerotic, where you don't want to do another internal fixation, where it's a very short fragment, where you also want to do lengthening, and you can't do using very good internal fixation methods. So the Taylor spatial frame and the later generation of hexapods have given us the 3rd generation ability, the 3rd generation tools to do this in a sophisticated and a smart manner. It makes us feel we are keeping up with the times. It makes the patients feel they're keeping up with the times, that they have had some sophistication in their treatment, that it's not just a system of crude rings, etc., even though, it's very powerful. I had a very telling example. I had a young lady who came to me from Mumbai. She's a student. She was in Bombay Scottish Orphanage, and she had the Taylor spatial frame. And at the end, something went, this is long ago, 15 years ago, something went wrong, and I converted it to the Elizarov struts, and we did the calculations and changed it. And she tells me, you know what, doctor, this seems more scientific to me now. And she was happy when we put on the Elizarov struts too. So everything is in the eye of the beholder. So we can correct any of these deformities, in different planes. It doesn't matter. You can correct the rotation, especially where the soft tissues are poor, get the perfect length, perfect alignment with TSF every time. You can tailor make it to this young lad who has a shortening and varus, but the other side also has varus. So you can fine tune the varus to make it match with the other side as well, and do whatever is needed to keep your patients happy and getting the result that they need. I will end this session again with an example of Blount's disease. This young lady with this, you can see this intra-articular deformity like so over here, as well as a very dramatic varus and internal rotation deformity much lower down in the tibia, along with procurvatum, not to miss. So when we start the TSF program, you have to choose the side, you have to choose the level of the limb, like so, very accurately. And then you have to fill up the deformity parameters. Here I have filled up 16 degrees of varus, 18 degrees of medial translation. Here the reference is proximal. Okay, so when you say it is medially translated, the distal fragment is medially translated, meaning the software understands that now I should translate the distal fragment laterally, which is what we want. The apex is, should be anterior. There is 6 degrees internal rotation, and it's about 6 mm short. And this is the most crucial dialogue in the Taylor spatial frame. This makes the software understand where the bone is. So from the reference ring, which is at the upper tibia, the origin, which is in the proximal fragment at the osteotomy site. So the center of ring is 22 millimeters lateral to the origin, 16 millimeters posterior to the origin, and it is 90 millimeters proximal to the origin. And the ring itself over here, the rotary frame offset, has been placed 22 degrees. You calculate by the number of holes. So now the software knows exactly how the limb is placed. And the second osteotomy is affected by the Taylor spatial frame. And these are the strut settings. Initially, it gives you the final strut settings. And this creates the program like so. Okay. And in case you want to make changes, something happens and you don't like what's happening. So over here, if you click on this point, from this point onwards, it'll keep the frame references the same. You can enter a new set of deformity parameters and get a very accurate correction of the newer, whatever residual problem is there. So here she was with the fixator. We eventually convert them to TSF struts, and here she is with a straight limb. So thank you very much. This comes to the end of the third generation 3G of deformity correction. We will now take a short break, and we still have the fourth generation to go. So I can take questions, and with your permission, I will answer questions, but with your permission, I'll go off the screen for just a minute, but I'll be listening and answering.
Okay. Then I'll ask the question, not the one which you can see on the screen, but we know that you treated the scion of Toyota family and you increased his height. What was exactly the final height he gained? And at what point of your treatment you realized that he is from that great Toyota family?
Shiva?
Yes.
We are on national webinar.
Yes.
Somebody will want to kill me.
Okay.
Let's not talk about this further.
No, you can talk about the height, because that's the question I have received. What the
4.5 inches. But that's in all 4 segments combined. It's a very conservative. I don't like to talk about cosmetic lengthening very, very honestly. Yes. I don't like to talk about cosmetic lengthening. I don't promote it. I don't advertise it. I may do one in a year or one in 2 years. I have to like the person. I do not do it for money. Though I don't have lots of it, I will not do it for the sake of money, because there are many.
When it doesn't, your conscience doesn't approve, it's better not to do it.
Number one, and these patients have unrealistic expectations, There are many things. I don't want to really talk about cosmetic lengthening here. You will excuse me.
Yes.
We'll go on to the next.
Anyway, our topic is deformity correction. That's fine.
Yes.
So there is a question. What is your opinion about treating intracapsular fracture neck femur with a Elizarov? Okay,
I have done this in 1991. I had a patient who had a fracture neck femur. We put in 3 screws. That failed. Then we did a subtrochanteric valgus osteotomy. Unfortunately, that failed. And then I really, without a C-arm, I fixed his proximal. I fixed his, with 5 or 6 wires, and with a Russian arch, and it succeeded. His fracture neck femur healed. I've shown this in several conferences previously, but nowadays I will not. I will do a vascularized fibular graft. I will do BDSF, that's biplanar double support screw fixation for intracapsular fractures. I will do a subtrochanteric valgus osteotomy. All of these are very standard techniques. I will not touch the Elizarov for these unless there's some really exceptional reason. Okay, radius ulna also I have done in the past, but really in today's day and age, there's no need for us to talk. I'm not one of these. I'm a product of KM Hospital. I have great teachers. I follow standard orthopedics. I don't think there is any need for us to think like this about radius ulna or fracture neck femur today. Please, thank you.
Yes. The next question is, how do you address a major bone loss of femur, especially in this era of mascule, whether you use mascule technique or Elizero?
With due respect to the questioner and to you, I think masculase is not part of today's debate. And when you say era of mascule, you're trying to presume that mascule has come and Elizero is gone. Huh? Mascule aaya, Elizero gaya. Sorry, sir.
No, that's a much more easier way of treating. That's why if you are given the choice whether to use mascule or Elizero,
okay,
what you will prefer? It's your personal preference.
I will answer only in one sentence. If it succeeds, the mascule is very expensive. Number one, mascule showed that his mean number of operative interventions that he had to perform was at least 6.3. The cost of everything is very high. And if it fails, that is the cost of getting all that graft in that huge amount of graft. And if it gets infected, it fails. If you do a reamer irrigator, I have a reamer irrigator aspirator system. I was the second person in India to get it after Dr. Chandak in Nagpur. I have it since last so many years. I have used it. I use very judiciously mascule because mascule can fail. The bone transport has not yet, touch wood, failed in my hands. I'll be very judicious with mascule and not use it everywhere. And it has not displaced the Elizero, but this is not today's subject. Next, please.
Yeah, that's fine. No, you can go with your presentation. That's all the questions I have at this stage.
Let me get the next presentation online and then it'll take me a minute.
Yes.
Okay, gentlemen,
yes.
It's time for us to move on to the fourth generation, 4G, fourth generation of deformity correction. Okay, now, fourth generation is, so Nicolas Andri was the first generation, Elizero was the second, 6-axis correction with external fixation was the third, and fourth generation is fixator assisted internal fixation or hybrid fixation using both external and internal because we want to reduce time and improve patient comfort. Okay. This is a very favorite artist of mine. This is Salvador Dali. There is a museum for Salvador Dali in St. Petersburg in Florida, where all the rich people live. Salvador Dali is a very famous Spanish painter with fabulous mustaches. And he drew these, surreal photographs of, time. The lesson about Salvador Dali is as follows. Time hangs very heavy for the patient who's wearing a fixator. Most patients in today's day and age, what has happened? India has changed from the time I started practice. People had lots of time, lots of patience, very little money, a lot of ingenuity, and the ability to cope with hardships in India. That was the India I started working in. In today's India, people have money, people have comforts, people have technology, people have information, people don't have time, and people are not stoic. They don't have resilience so much, I think. So people don't want to be stuck in a fixator for a long time.
I think now Corona is teaching us. This Corona is teaching us
patience all the way back.
Patience and all those things. Yeah.
Right. So, we are all in search of the holy grail, the final answer, that is internal fixation for everything. And you know very well that fit bone, precise, which I'm going to talk about briefly, these are so expensive. And in the US and in Europe, they're doing everything with fit bone and with precise and albizia, and they're so expensive, our patients can't afford it. So what should we do? Should we eat humble pie? Or should we use the things that we have, that is external and internal fixation? So 4G is about hybrid X-fix plus infix. We can do single or double level fixator assisted nailing, plating, etc. So let's talk about lengthening and deformity correction over a nail. This is a young lady who has genu valgum, 3 centimeters of shortening. If I were to put an LRS fixator, she would be comfortable. But with lengthening 3 centimeters, I will be able to do a good job of correction, surely. But the fixator will stay on her leg for at least 5 to 6 months. When that happens, there's a very high chance that the knee will become stiff. There's a very high chance she'll not go to college because she's embarrassed by the fixator. So what we do is we analyze, we take proper full length x-rays, we pass in a nail from the distal end, we do the required lateral translation of the distal fragment, lock the nail distally, keep it free proximally, use the polar screws to narrow the track of the nail. These are integral components of deformity correction. Use the fixator to lengthen. You see this tiny incision over here? And very good correction of the axis. Fixator comes off in 4 or 5 weeks, and she has got full range of motion. Even though after the fixator comes off, she uses a walker, fixator comes off in 1.5 months. That's nothing. So this is the great benefit of hybrid internal fixation. As opposed to that, for somebody for whom we couldn't use this method, this is a chondroblastoma tumor excised, a lot of shortening, and we had to use external fixation. There was no choice, the TSF. And for 5 centimeters, it took him 9 months of fixator treatment. Though he's got a perfect limb and he's going to do well, the fixator duration is really dramatically high. So let me straight come to double level correction with an intramedullary nail. This is a subject very close to my heart. I've done a lot of innovation in this. We've spent a lot of time, taken a lot of radiation and created instruments. So when we want to perform 2 different tasks at 2 level deformities, we can use this. You need these special instruments, okay? That's a full length X-ray for a start. You need straight rigid reamers, cannulated reamers. You need straight nails. You need polar screws. These are made by Uma Surgicals. The reamers are made by Manman for me. Very kindly, they helped with this project. This is a starting point jig for the lower femur at 81 degrees, ALDFA. Anatomical lateral distal femoral angle is 81 degrees, you know. So we've created a jig. These 2 prongs rest against the femoral condyles percutaneously, and we pass in the guide wire at 81 degrees, okay? So over the guide wire, these instruments go to narrow the track. These are thin-walled reamers or clovers, and these are bushings which maintain the track of the entry point of the nail. And this is the entire set that Manman has created. And this is a complete paradigm shift, okay? External fixation is okay, but now we are entering a new level. You have to do a lot of planning, proximal or distal entry. You have to decide the location of the central holes and accurately localize the osteotomy. So let me explain by showing you examples. This is a severe valgus and procurvatum deformity. All right, this is India. Now, if I were to use an LRS or a Ilizarov or a TSF fixator for this gentleman, then it will be perfect, but the fixator will be on for such a long time. Or I can do a closing wedge osteotomy and correct it here, but then there is again there is a deformity here. There is a procurvatum deformity. So what to do? So we chose to perform double level fixator assisted nailing. This is the entry point of the nail. First, the titanium pins are placed posterior to the intended track of the nail. Over the guide wire, this thin guiding device goes, and you can see where the reamer is going to go, the pins are posterior to the track of the nail. The guide wire has gone. You have determined at 81 degrees where the guide wire should go. This is a marker. The guide wire goes. The next, this is the instrument that goes. These are the thin-walled reamers that have created this track. Then the most important thing is we put these polar screws to narrow the track. Otherwise, when you try to correct, the reamer and the nail will just move in the wide metaphysis, okay? And so these polar screws keep the nail in the track. They direct the traffic of the nail. You can see the pins are posterior to the track of the nail, all right? And hopefully this animation should show how we do this. So this is the joint orientation line. The MLDFA is 70. We put in the pins posterior to the track of the nail. Put this jig. This is at 81 degrees. The wire is passed. The reamers are passed over here. Okay, the 2 polar screws. Then we create the outline of the osteotomy. And then with the help of the reamer and the osteotome, we translate it. See this lateral translation here. And the second osteotomy, and the reamer is passed on top. And then the nail goes in, and you can do this. The second osteotomy is typically required in the procurvatum phase. This is the hidden deformity, and which is what we did for this gentleman. Okay, so the LRS fixator was retained just for a couple of days, just for my insurance. And here is one osteotomy with the significant translation of the distal fragment. This osteotomy is actually correcting the procurvatum, okay? And there are central holes which we accurately localize to fix both the osteotomies. The Ilizarov does a good job of, medial translation of the distal fragment here. Some deformity is corrected by Ilizarov is easy to tolerate in the tibia. It's very easy, not a problem. But femur, no. The fixator came off in 10 days, And here he is, one limb is completely corrected, okay? Absolutely straight. The axis is perfectly in the center. And you see this lateral translation, you see the two polar screws, how they have narrowed the track of the nail. And you can see the procurvatum is also nicely corrected. In the same manner, the second side was also corrected. You see the very nice medial translation with the Elizarov here. You see the lateral translation, see the polar screws, and he has a limb with limbs which are very straight. There has been no fixator on his femur for more than 7 days. This is what we can achieve compared to what we start with. And the fixator assisted nailing double level allows us to correct the obvious and the hidden deformities as well. Some other examples. If there's a malunion in this gentleman, poor quality bone, some shortening. So we start with a proximal entry of the nail. Okay, this is a proximal entry. We have created holes over here. We keep it long. We make the drill hole over here from the very beginning. And then we do the osteotomy, correct the varus deformity, fix the nail distally and in the center, lengthen through this side. The nail slides in with the LRS fixator. It comes out quickly. The external fixation duration is rather short. The length is achieved. The fixator is removed very quickly. And he is having almost the same alignment as on the other side. In contrast, if you do with external fixation, say in younger children, you have to. This girl had a growth arrest. We did this physiolysis, and then we corrected her and over-corrected her. It took a lot of time, almost 2 months per centimeter, even at the age of 12 years. So in comparison, no fixator versus fixator is really a very big difference. You can do it for a non-union like this. Okay, my trauma surgeon friends, you can wake up. You need not, ignore the shortening anymore. So this patient is short, he's not infected. Primary requirement, no infection in these cases. And the nail may be broken or not broken. The end may be sclerotic. So what we do is again a proximal entry of the nail. The nail has come down. We have done the shingling percutaneously. I'll need to put on a battery. And we have done the shingling, and over here, and we have compressed before locking the nail. You know how to do this. It's easy. All of us know how to do this. And we have performed the proximal lengthening. So by doing that, we have achieved all our targets, and the fixator comes off in a really quick time in 2 months. And because of the lengthening, it also allows the non-union to consolidate. See, here he is, very good healing, and very quickly after fixator removal, good function. Fixator is only less than 2 months. So my friends who are doing trauma, remember with non-union, non-infected, not only nailing and plating, you can also give them length. In contrast, for an infected non-union, for a lengthening also needed of 8 centimeters, it has taken him close to a year of treatment. But of course, it's mandatory because I put in an ABC nail. And if I were to put in a nail inside, it probably get recrudescence. So he needs an LRS treatment only. And these are different animals. And the prerequisite for deformity correction using IM nails is no infection, please. Okay. So here we are. And now let me come to my other favorite subject. That's supracondylar osteotomy in poliomyelitis. So Shiva, you were very kind enough to point out that I have got the Service Above Self award. So you are a Rotarian, you understand the importance of this. I was a Rotarian for a long time. And I treated a lot of polio patients, not in the classic camp model that people did in India, in cities like Vizag and Udaipur, or people did in Africa. No disrespect meant to anyone. I created a white paper. I circulated it in Rotary International. I gave lectures everywhere. But I treated more than 1,000 patients completely free of cost with the Elizarov, with the latest gadgets at the rate of 2 per week. I gave them the entire dignity, all the resources, the full length x-rays, the Elizarov, the plating, the hospitalization, the same dedicated care. A time in the week was reserved for the surgery. A time was reserved for the follow-up. They were treated with dignity and not like, in a camp sitting where hundreds and thousands were treated, So the supracondylar osteotomy, you can see the center of rotation of the knee is here. The FFD and no quadriceps function, so they collapse. The classic osteotomy is resection of a wedge. It does straighten it out, but the center of gravity, which is this green line, which was posterior here, is not yet going anterior. So it works, but not so well. With the rule 2 of Elizarov, what we do is we posteriorly translate the distal fragment, okay? The deformity is in the joint, but the osteotomy is above. So we posteriorly translate it. And now the center of gravity goes in front of the center of rotation of the knee, and it helps to lock the center of rotation. So it gets, it's less angulation and you can achieve the result. This is a television actor from Mumbai. You can notice the subtle FFD. He walks with a lurch, some shortening, high quality X-rays. The nail is used for templating. We use a distal portal. You can see the posterior translation of the distal fragment. You can see the polar screw here. The intervening fragment is locked. The LRS fixator is above the nail here. You achieve the length of 2.5 centimeters in a month. The fixator comes off, and here he is, everything heals up, and the limb is straight. His lurch is gone. I know he's happy because he brought several members of his family for treatment to me. So the use of the polar screws in deformity correction using IM nails is very crucial. I've been doing this since the year 2008. You see this significant procurvatum. The other thing I've noticed about polio is the procurvatum is all over the place. It may be in the proximal femur, middle femur, distal femur, very distal femur, or only in the knee joint. So 2 osteotomies, 1 osteotomy here. Okay, the second osteotomy here for the procurvatum. At 2 levels, we correct the procurvatum. This is a crucial deformity to correct. And the polar screws help to keep the track of the nail and also achieve length like this in a very short time. So this is a diagram from my article in British JBJS. So with a proximal portal, we angulate from posterior to anterior. These pins up behind the track of the nail. Where it hits the anterior cortex, we do the first osteotomy, correct it, go down. At the second level, again we ream, and we are able to lengthen and correct both these problems with a very short fixator duration. So this gentleman, again, I can't see the screen, but had a very short time for 5 centimeters length. Again, polio, he's a pharmacist in Bangalore, so he's walking much better. They improve by 30, 40, 50%. Okay, I'm not a charlatan. I'm not going to say 100%. I'm just like you or anybody else. I will only say that they improve by 40 or 50%. But the improvement in the length and the procurvatum correction makes the gait less tiring, and they're less prone to arthritis. So we improve them, but they don't become normal. If you understand that, if the polio patient, if you don't create the hype, if you don't treat them like animals in hundreds of them in one sitting. Now, of course, the new cases are not there, but I'm still treating 1 every week. Once every fortnight, I've got patients I treat with the best equipment and short time with great care. I don't have one formula for everything. That's what's wrong with, I think, today's brand of orthopedic Shiva, if I may digress. Everybody wants to, this is the way I do it. I do everything in this way. It's about, it's about HTO, it's about polio. People do it.
Yeah.
You must give tailor-made treatment, bespoke treatment. Analyze the patient, his deformity, his requirements, and give the treatment under the circumstances best for the patient. Okay. So now, in contrast, some limbs in polio are so thin you can't do this. So here is an osteotomy and a lengthening with fixator. She got the 5 centimeters, but she's a doctor, but poor thing had to be in a fixator for 9, 10, 11 months. It's okay. She got the result. But this is the great benefit of 4G, okay? So recurvatum and shortening. This is a young man with Ollier's disease. You can see 60 degrees recurvatum and a lot of shortening. So we did again, you can see over the LRS, it was a long nail that I put in. I corrected the recurvatum. A second osteotomy here, only 1 screw. The nail has come in and he has got 9 centimeters in the femur. Fixator has come out quite soon. A little bit of lengthening in the tibia. And he gets his result, correction of the deformities and equal leg lengths with minimum fixator time. As opposed to that, somebody again with Ollier's disease, again a young doctor, we tried, there were technical considerations, we couldn't put in a nail. So he had a double level fixator in the femur, and for a lot of lengthening he got a good result, but the fixator stayed on the leg for a really long time. So the double level fixator assisted nailing is a great boon. The duration of external fixation goes down dramatically, half. We compared our double level X-fix and double level nailings. The duration of X-fix has gone down to half. The days per centimeter has gone down to half, from 45 days per centimeter with double level fixator to 23 days per centimeter. And it's indeed a great boon. The same 4G now, the concept is not only lengthening, but you have genu valgum. So what we do is we marry the accuracy of the TSF external fixator and the convenience of the locking plate internal fixation. So you can see the TSF is placed and it's open laterally. We take X-rays on the table, we do the programming. A small incision allows us to outline the dome osteotomy and also slide in the plate and insert it percutaneously to give a good correction. Now, this is a very interesting story. This girl is a daughter of a general surgeon. She comes from a particular community. I'm sorry, I forget the name. Apparently, she's the first female child born in that community in 200 years. So they tell me. And she develops this significant varus deformity and shortening. A lot of deformity. So we corrected fixator assisted nailing. You see this? 4th generation. This is medial translation. In varus deformity, medial translation of distal fragment, the nail goes in, polar screw, the nail is locked distally, kept free proximally. Complete the lengthening of 4 centimeters over here. And in a month and a half, everything comes out. The fixator on the tibia can stay. Nobody's worried about tibia fixator. It's easy to tolerate. The femur comes out very quickly. Everything is aligned and range of motion is full. That's the great benefit. It's not just time, it is also about joint function. If you keep the fixators on, whichever fixator it may be for a long time, you are going to have joint stiffness. So the great advantage of this method is reduced time and reduced joint stiffness. So this is the paper we wrote in British Journal of Bone and Joint Surgery. Last year it got published. Now we have, done upwards of 45 segments with double level fixator assisted nailing. It's a great technique. It can take us 4 hours. It can take us 2 hours, a lot of radiation and, it's a different surgery, but it's very good for the patient. And I'm so happy. I actually showed my fixator assisted nailings in Kurgan Institute in Russia in 2012. And they got started after seeing my talk. And it is a matter of great privilege and honor for me that I was given the honored professor's title in 2016 at the Kurgan Institute in a ceremony with some others. Dror likes to point out that his first student became a professor in Kurgan before he did. So Dror is also a professor at the Kurgan Institute now. But it means nothing except the fact that I'm very grateful to the Kurgan Institute because I learned a lot. Because everything you learn from the West, you cannot apply in India. And there are so many things in the Kurgan Institute about the Elizabeth they know that we still don't know. They are fantastic techniques. So because I showed them these things and because of my long association with them, I've had the great honor and privilege of currently the only Indian who's a professor there. And this is the technique that I want to emphasize. So we are up with the times. It's not just Elizarov. We're not doing old stuff. This is cutting edge science. And the only, now people in the US, when they're doing lengthening and deformity correction, they're using precise nails. And they're so expensive. They're using a nail for lengthening and a locking plate at a second level. Whereas I'm using a nail that doesn't cost more than 4,000-5,000 rupees and a LRS fixator. The surgery is difficult, but for the patient, it's a boon. You can do 2 tasks in 1 surgery. So I think this concludes this part of the session. And I'll log out of the video for a minute, but I'm listening and I will answer questions. Can you hear Shiva?
Yeah, we are here, sir.
Yeah. So are there any failures? Yes, Professor Herode, we have had our failures. I can tell you that I had a patient who had a previous infection and we did deformity correction and lengthening because we thought 3 years had passed after the infection. But the patient happened to be a borderline diabetic. The diabetes flared up and the infection flared up and we had to remove this. In the single level fixator assisted nailings, lengthening over nails, we've had a 5% rate of deep infection, okay? We have 5% rate of deep infection. And the treatment for that, if the infection happens, it has happened to me while the regenerate is soft. It has happened to me while the regenerate after the regenerate has hardened also. So if it happens when the regenerate is soft, you have to retain the external fixator, ream the canal, put in an antibiotic impregnated nail, do the culture, do the full treatment for the infection, whatever it warrants, and continue the treatment with external fixation. And if you're lucky and the infection comes when everything is over, then you can just remove the nail. And yes, like I said, for the single level lengthenings, it has happened in 5% of the cases, which by now means I've had close to 9 or 10 infections. Okay, we've crossed 100 sometime back.
Okay. There is a question from Dr. Milind Gandhi.
Yes.
He asks one kind request to simplify or teach us cheat sheets for deformity correction in future talks. You
Yes,
said that there are simpler version cheat sheets. So
yes, Milind, my now bandhu, I have this talk on cheat sheet. You don't have to do calculations. You just have to keep in mind lower femoral valgus, translate the distal fragment laterally. That's it. Lower femoral varus, translate the distal fragment medially. That's it. Don't do the calculations. Subtrochanteric valgus, subtrochanteric varus, you're trying to correct, you translate the distal fragment laterally. If you're correcting valgus in the upper end of the tibia, translate the distal fragment medially. Yes, we use simple rules of the thumb. Okay.
Yes. Another question from Dr. Nikhil Agrawal. Any experience in using Ilizaro distraction neogenesis in diabetic hypovascular wound and ulcers?
Thank you, Dr. Nikhil. But I have restricted my use of the Ilizaro to the TAO cases and to now some atherosclerotic cases. I know that it can be done in diabetes, but the thing is it requires a lot of coordination with the people who do use and who do treat all the various aspects of the diabetic problem the patients face. And I have not yet drummed up the courage. But one day when I have enough support, in judicious number of cases, I think I will start doing in a very judicious amount. I know that there is literature from Russia and it can be done. Okay.
Yeah. The next question is from where do you get these special nails, straight nails? Is it Manman only manufacturing or somebody else?
Yes. It's an easy question to answer. Girish of Uma Surgicals was kind enough to get me started on this method. If he makes the straight nails and
okay.
Straight nails are with Uma Surgicals. No problem. Just ask him.
Okay. Is it a universal nail or you get custom made for each nail? Because here you can see that the interlocking for the middle segment has been done too near to the corticosum site.
Yes, it's custom made. Now that's the difficult part of this. Okay.
Yes.
That's the difficult part of this procedure. That is, now you have to do the planning for each patient to determine the location of the central holes. This is an interesting issue. And there are very many different solutions for this. Based on what I heard about CAD-CAM in Belgium, I also have a setup where I can create the holes on the table. And I can do passivation, I can do ultrasonic cleaning and flash autoclave of the nail, okay? I can do that. I have created a system, but ideally one needs to get the holes pre-manufactured at a particular length after you have seen the patient and analyzed the deformity, and then you look at them. And then you do it.
Yes. Okay.
Then you do it. Then you do the nail after you got the custom made. Yes.
Okay. Are you happy with this interlocking board so near the corticotomy site?
It doesn't matter.
Okay.
It doesn't matter. But if the holes are not filled and the nail is of small diameter, it can fracture. It has happened to me once. So what's really important is to have both the holes filled. If the hole is close to it's a percutaneous corticotomy.
Okay. Actually, that is the next question from Dr. Milind Joshi, one of your fellow in the 90s. As a straight nail is used, do you end up using a small diameter nail when using a fixator assisted nailing for deformity correction is the next question.
Yes. See, that's a part of the struggle. So in polio, some of the diameters are so small that we can't use this method. We have to give it up. There are other technical reasons it may not happen. But when you're using a very small nail, the problem, we had a fracture in the nail in a girl who had cerebral palsy and she was having spasms. And she had a thin nail, okay? And one of the holes was not filled. But otherwise, if the patient is not thick set, Even if it's a thin nail, it doesn't matter, but you protect it for longer time. You can keep the fixator longer, you can give a brace for a long time. So you have to go, with the flow and take care of problems.
Okay, the next question again from Nikhil Agarwal. The choice of shunt screws to be used regarding size, tapered or non-tapered, HA coated or anything else, whether the screws are titanium, what is your recommendation?
I'll give you some tips. We learned that even though LRS Orthofix makes beautiful HA coated and expensive half pins, Uma Surgicals makes a very nice titanium half pin which is tapered, 5 to 4 mm, and pediatric ones which are 4 to 3 mm taper. The beauty about this is that when you're trying to place these pins posterior to the track of the nail, if the half pins are not perfectly parallel, the titanium is elastic enough and it allows you to put the LRS fixator in place, unlike the strong and stiff stainless pins which may result in some difficulties. So titanium pins.
Yeah. Last question before we move on to the next part. Dr. Nitin Deshpande, past president of Maharashtra Orthopedic Association from Kolhapur, he asked,
Yes, sir.
can you opine about the Elizero courses conducted at many places where it is claimed are the best only course and the pictures published with rings applied to skull to spine to toes?
Why do you ask me difficult questions?
It's me, it's not asked. It is the Dr. Nitin Deshpande. I have taken the name.
No comment, please.
Yes, okay, that's fine. You can start sharing your next presentation. Yes. I think that's the last part.
Give me a moment while I get the next. So, Shiva, please tell me what's the, how are we doing? Because now it depends on the audience and it depends upon you. You're the best judge.
No, we will do it because people will see it after recorded version also, so that everything will be there in one go. Yeah.
All right. So I will not take a lot.
Normally, at present, we have got about 2,500 to 2,700 people watching live, but by tomorrow, another 3,000 to 4,000 will be seeing the recorded version. So let's finish it.
All right. So thank you. So now I want to share my experience in the treatment of the commonest deformity the orthopedic surgeon sees in the outpatients. Okay. That's the varus knee giving rise to medial compartment osteoarthritis. So this talk we are going to end with 5th generation of deformity correction, 5G, which is also an HTO nail. And in the process, I want to talk about the commonest deformity that every adult orthopedic surgeon sees. So modern high tibial osteotomy, this talk is going to be about its development and the directions in which it's going to take. Now, I want you to focus on the 7 factors you need to take into consideration while performing any kind of high tibial osteotomy. But before that, I'm running ahead of myself. I have always been saying, I've been telling my fellows and whoever who cares to listen, that I think in orthopedics, an HTO should be the commonest elective surgery. It's a big statement. It's a bold statement, but I think it's really true because an HTO done early really helps the patients. And there's a lot of confusion. HTO must be done early. HTO, modern HTO in its modern avatar is a very reliable operation. It's not very easy. It takes some time, a lot of effort, some calculations. There is a learning curve, but it will help your patients dramatically. Okay. So now, having said that, there are 7 factors we need to take into consideration. There's a varus in the tibia. There's a varus in the femur. There can be an intra-articular varus. I'll come to that as a condylar plateau angle or a joint line convergence angle. There may be alterations in the slope, or they may be present, or you may need to make them. There may be a rotational or a torsional deformity that's typically in torsion, which adds to the varus. There may be a leg length difference, and there will be a dynamic varus deformity, which you observe when the patient is walking. So when you observe these, when you take into consideration all of these, that is when you decide which type of osteotomy and where you need to perform it. It's not just one size fit all. Okay. So why do we do it? Because an osteotomy gives definite and confident relief of pain, and the duration of pain relief depends upon the accuracy of the deformity correction that you have performed. And there are other factors which I will talk about. So which level, with which hardware, and how much correction. These are the thoughts that you need to. But firstly, we must all forget and unlearn the propaganda that we have been told that cartilage cannot regenerate. This is by our friends, the joint replacement surgeons whom we love, honor, and respect very much, that cartilage cannot regenerate. Well, this is a photograph taken from Dr. Koshino's work in Japan. And this talk is going to be about my homage to Professor Koshino. He was the president of Japan Orthopedic Association, the Asia Pacific Knee Society. He was a great surgeon, came to India many times. We held the first HTO conference in Jaslok Hospital in Mumbai 2010, 10 years ago exactly, at this time. So he has shown in a second look surgery at the time of implant removal that cartilage which is worn out like this, at the end of 1.5 years, can regenerate quite well. In at least 30 to 40% of the cases, the cartilage regenerates as well as this. The requirement, according to him, is that the correction of the axis must be good. In Dr. Koshino's words, you must aim for 10 degrees of femorotibial valgus angle. And he was the one who started very early. So Dr. Koshino worked with, Dr. Koshino and Dr. Ranawat were co-fellows at the Hospital for Special Surgery in New York. And Dr. Ranawat was working in the rheumatology department. He did a lot of work in rheumatoid hands, rheumatoid cervical spine. And Dr. Koshino was working with Insall and Bauer. He wrote the first paper with Insall. The classic paper of Insall is with Koshino. And Dr. Koshino went back to Japan. Dr. Ranawat stuck on in New York and did joint replacement. Koshino went back and he saw that the Japanese ladies need to sit down. So he developed a plating system. He developed a barrel plate system. He developed an angled blade plate, a barrel plate to give very secure fixation, which allowed controlled collapse and did not allow the varus valgus to increase or decrease, as opposed to the staples that were being used by Coventry and other people. So he is a great man. He saw the need for accuracy. And, I visited him in 2004 in Japan. And from that time, I stopped doing only Elizarov for HTO. Can you guess how much time it took him to do an HTO? After having done thousands of them, he took all of 2 hours and 15 minutes. Our surgeons in India take so much pride in doing osteotomy in 15 minutes. Why does he do that? Because the result should be long lasting and cartilage can regenerate. So let's look at history. Of course, Robert Jones, the father of modern orthopedics, performed mid-tibial osteotomies in the mid-1850s, in the middle of the 19th century for osteoarthritis. We all know the paper by Jackson and Waugh from Nottingham. They actually did not describe a closing wedge. They described 12 different types. Can you see the dome? Can you see the dome here below the tuberosity? Just above the 12 different types. Even in 1958 and 61, there was somebody who was saying, you don't do things only in one way. You modify things according to the circumstances. So the closing wedge osteotomy was very popular. Mark Coventry, who was from Rochester, Minnesota, from the Mayo Clinic, the charismatic and handsome Mark Coventry started it. But then within a few years, he was getting poor results because of plaster casting and staples. And he was recruited by the industry to promote joint replacement, which is why he jumped ship. And the development of HTO in the USA took a backseat, but it continued in Japan. Okay. So though we all know Coventry's osteotomy, Coventry did not continue to develop the osteotomy. So this is Professor Tomihisa Koshino, this photograph taken in Mumbai 2010. Unfortunately, he's no more. He passed away due to cancer about 2 years ago. He worked most of his life in Yokohama and in a small city called Yaizu City on the Suruga Bay. You can see Mount Fuji from where he worked. A beautiful view of Mount Fuji. He was at Yokohama. He was a professor, head of the department for so many years. He's published a huge book. Okay, I have this book. I'll show it to you in a minute. So this is given to me very kindly by him. This is a lifetime of his work. All right, presented by him, and a compilation of all his papers. One of the papers in this book is about knee range for floor sitting, performing high tibial osteotomy for floor sitting. Okay. So this is Professor Koshino, and he wrote this article with Bauer and Insall. And this is 1969, okay? And he developed the angle blade plate, and he refined the methods of doing the closing wedge osteotomy. And for years and years, he did thousands of these. His patients did, this is one of his patients. This is me in 2004 with him. This is the paper in the journal Knee 2002. increase in the range of knee motion to obtain floor sitting. This is the original high flex knee in Japan. And he grades his results based on the amount of time the patient can sit like this. Okay. So what he said was that my HTO is essentially a total knee replacement without the prosthesis. Because he opened everything, he released the patella retinaculae, he got rid of a lot of osteophytes to improve the range of motion also. And also some translation of the tibia, and also his patients should not be fat because a lot of popliteal fat prevents full range of motion. So this is his result on cartilage regeneration. And if you believe it, if you can do it accurately, it will regenerate and give you pain relief. So HTO revived in the West with the work of two people. Very important, Frank Noyes from Cincinnati, who is a great sports surgeon, who kept talking about HTO and primary varus, secondary varus, and tertiary varus deformities. Okay. And then came Maurizio Catani from Lecco, Italy, from near Milan in the Lombardy region. He's a very charismatic, happy-go-lucky golf-playing surgeon who hates radiation and was responsible. He's probably the most beloved teachers of the Elizarov techniques in the beginning. He came to India several times and he, did a lot of high tibial osteotomies and very successfully too. But of course, it was the work of Dror, who wrote about the focal dome osteotomy, I think in OCNA in 1994, which, set the stage for focal dome osteotomy so that, you could retain a large bony contact, correct large varus deformities, you could correct rotation because you made use of the theory and you had a dome which was convex distally and not proximally like in the Mackay's procedure. So he is responsible for so many things. So this is the focal dome osteotomy. You can fix it with the Elizarov. And you can see the gentle amount, lateral translation, little bit of lateral translation. So you don't angulate it too much, So the ankle joint doesn't suffer. The knee joint line doesn't tilt. You can do angulation and translation. Give sustained compression. It always unites. And you have to do a proximal fibular osteotomy. So these are some examples. This gentleman, you can see the intorsion on this side. He's 68. He's a bodybuilder. And he can easily tolerate this fixator. You see the lateral translation over here and external rotation. And he's very nicely corrected without too much tilt of the ankle or the knee joints. And when you need to perform on both sides at the same time and both are painful, the Elizarov is wonderful because, you can correct rotations as well, as opposed to the other fixators. And if you do it a little wrong, you can end up with procurvatum. With the Elizarov, you have 360-degree control. And it's not that uncomfortable. The rings are quite light. You can use carbon fiber and titanium half pins. But again, after having done focal dome for so many years, I started noticing when I went to Mumbai that patients are reluctant to get the fixator. And elderly ladies in their 60s don't want a fixator. So having seen Professor Koshino, I started performing fixator-assisted plating, where X-Fix is just an intraoperative alignment tool. So this lady in her mid-60s is 0% mechanical axis deviation, mild FFD, won't tolerate a fixator. So on the table, I have this large X-ray machine at 10 feet. I use a full-length cassette on the table. We put in an external fixator. It can be anything. It can be an Elizarov, it can be LRS, it can be a T-shaped fixator, fibular osteotomy. The fixator is passed, the osteotomy is outlined. We make the correction and we put in the plate on the table and come out without the fixator. And here she's a simple plate. This is a simple plate for this lady. This posterior translation is the external rotation. Very good correction and good function. No fixator is used. Slightly different indication. This gentleman is a very busy businessman. He travels in a Merc. He doesn't want to have a fixator, wants to get back to his factory. He has other deformities, but he says, no way, I want a fixator. So we do the fixator assisted, plating for him. We use the TSF for accuracy. We correct his deformities and we put in a medial Tomofix plate, the same strong, beautiful Tomofix plate. And he's walking very soon. He's short by almost 2 centimeters, but he wears a raise, is very nicely corrected, back to his job, completely united without problems. Now, everybody talks about you can't do HTO with patellofemoral arthritis. Don't worry, it's not a problem. What you have to do is retinacular release. So whenever we do an HTO and the patient has a patellofemoral pain, There are two options. You can do the tibial tubercle osteotomies, which are rather difficult, or you can perform this retinacular release. Christodoulou and Koshino both have written up about this. It's there in the literature. And also the work of A. Lee Dellon, who talks about a neurectomy of the patella. You know, when you release the retinaculum, you're getting rid of the painful nerves that are causing the patellofemoral pain. You also resect the osteophytes in the patellofemoral joint. So don't worry about it. So we've spoken about this in the past couple of webinars. The opening wedge osteotomy is the flavor of the season. And the man responsible is not the originator. This is Philippe Ernigout in his much younger days. He still looks more or less the same. He worked under a gentleman in Paris who started doing this in 1951 in a very big hospital in Paris. And Ernigout has done more than 4,000. He combines HTO with uses a very strong plate for early mobilization. And he also does it in combination with total knee replacements in the older patients. But 4,000 cases, and their experience of opening wedge paved the way for the modern opening wedge, which was designed by the AO people and the Tomofix system, the Japanese. So it was Debeye and Ernigout who have really, this is a European, and this is Stobly who was roped in to design the system from Lucerne in Switzerland. And he has a fabulous understanding of the whole system. The medial opening wedge, high tibial osteotomy using the Tomofix plate is a wonderful surgery. When it's done for mild to moderate deformities extending up to 0% mechanical axis deviation, in these cases, without too much flexion deformity, without too much rotation, without too much other problems, without any intra-articular deformity. In a middle-aged lady with a mild deformity, the Tomofix is fantastic, and for many cases. So this was their paper, Lobenhofer, Stobly, and this is a biplanar. In the small deformities, the tibial tuberosity can be cut angling upwards. The Tomofix uses the golden screw, which compresses the lateral hinge, and the elasticity of the plate allows micromotion, and the bone heals up. You don't need to use any, bone graft. This is the golden screw, which is giving, the plate gets pre-tensioned, and that sets up compression at the lateral hinge like this, okay? And you get this fabulous correction of these mild to moderate deformities. It's the best. This is a pathologist. This lady went to, from a district place in Maharashtra, went to Pune 2 times, had 2 arthroscopies. She's 47. And every time they're saying, let's do arthroscopy, you're too young for a total knee. Let's do arthroscopy, you're too young. Get rid of this confusion. There's no role for arthroscopy in the middle-aged, okay? It's there for the sportsman. I'm sorry to say, my friends, don't kill me. But medial compartment osteoarthritis with mild to moderate varus, you go for HTO. With the Tomofix system, this is a doctor. Her daughter's marriage is coming up in a couple of months. Within 5 months of the surgery, she got her daughter married. She's walking, she's doing everything in the home. I have so many doctors. They're getting their daughters are pregnant, they're due for a delivery. They do the surgery few months before the delivery. They're happy, they can do everything at home. And there's so much literature on this subject now, so much, especially in the journal KSSTA, that this analysis, this is from British JBJS, the analysis that osteotomy must end in this WL zone. That's within the proximal tibiofibular joint, and it must be lateral. It must not end medially. It must not end above. It must not end below. It must end in this zone, and then you'll get a perfect result. So like Professor Stobly says, you get one shot at doing this right. You do it carefully, there is a learning curve. This gentleman, for those who have seen, I apologize, an orthopedic surgeon, mild varus deformity, 24 degrees. I'm sorry, the line has shifted, but it's 24. He's had an ACL reconstruction. He wants to run. He's got a mild varus. So we chose to perform a medial opening wedge. Look at this, very small wedge. And we corrected him only to 54%. All athletes and sportsmen must not get overcorrection into valgus, okay? And the Tomofix allowed him to mobilize early. He drove back in 54 hours, and he was back at his clinic in 7 days. And, but he guarded, he's an intelligent, smart orthopedic surgeon. He took some time before he put full weight. And now these are videos he kindly sent. This is not going to run, I'm sorry. He says he ran 30 kilometers in the lockdown period. He can squat, he can climb upstairs. There's something wrong with the videos. I've shown them before. I apologize. But that's the result you can get with with a medial compartment. Now, okay, this lady comes to us from Madhya Pradesh, and she has pain in the right knee. Mild deformity, you don't even have to think. A tomo fix, a wedge about 12 millimeters big, no bone graft, fabulous result. And then she comes back saying, "Mera dusra pair bhi dukh raha hai." So you carefully analyze this. So what we did was a gentle bit of a focal dome with translation, because the deformity is at this level, not at the level above. And at that, she has a malunion here. So we use the TSF. We corrected the deformity, which is varus, internal rotation, and shortening. We corrected everything. Sorry about the photograph, but now she's completely equal in lengths, perfect mechanical axis. So horses for courses. You do justice to the problem, treat every patient individually. What do you have? A femur varus. So there is enough literature. Like I said, this is KSSTA. If you do a large correction in an opening wedge osteotomy, then you're going to have obliquity of the knee joint surface. So this lady, again, I have shown this. Somebody told me you can't see the varus. Please, sir, if you draw the lines carefully, if you're used to measuring, and me and my fellows have been measuring thousands of measurements in this lockdown period, you have to do it right. You have to measure carefully. You see a lot of varus over here. Varus in the femur and the tibia. There's also this condylar plateau angle. So we corrected with double level fixator assisted nailing, and we did a TCVO, intra-articular osteotomy. I'll come to that. On this side, and on the opposite side, nailing for the femur and a double osteotomy for the tibia, okay? And here she is, completely corrected axis, free from pain, mechanical axis running through about 55 to 60 degrees, and full correction of the deformity. So finally, we come to intra-articular osteotomies. These were started in Nagasaki by Professor Shiba. At that time, Professor Teramoto was with him in Nagasaki. And now we were exposed to this in Asami International 2014. Professor Teramoto came and he gave this most wonderful lecture for 10 minutes. Everybody was laughing. And he was laughing too. But he's having the last laugh. And I've heard his compatriot, Professor Matsushita, who's a professor at Teikyo University in Tokyo City. These are not small town hicks, These people they know what they're talking about. Professor Matsushita is on the record for saying there is no other osteotomy than an intra-articular. That really should be done. But let's be objective and balanced. So he wrote in the Journal of Limb Lengthening and Reconstruction, which I edit, which is the official journal of LLRS North America, as well as Asami International and LLRS International and Asami India. Please log on to the journal, JLLR, Journal of Limb Lengthening and Reconstruction. Fantastic articles are there from all over the world. Read the journal, review for the journal, please, and write for the journal. It will enhance your understanding of limb reconstruction and deformities. So he wrote about this. So in a patient like this, where is the deformity? You can see this is a pagoda tibia. It's in the joint and also extra-articular, large mechanical axis deviation. These are the lines, okay? So deformity is in both the places. Over here, the varus MPTA shows, and this is the condylar plateau angle. And there's an obvious varus in the upper part. So, these are different patients. So the deformity is present also in the joint, also in the extra-articular zone, but more in the joint. So this is a lady who has a lot of pain in her right knee. You can see this carefully. And this is the surgical technique. This is an L-shaped osteotomy. And this is the vertical cut. 2 wires are guiding it. This is gently cutting just the edge of the intra-articular part under C-arm control. This is the medial cut now. Everything is under C-arm control. The posterior cut is done very carefully. And with a spreader, we spread apart the medial tibial condyle and we elevate it like so, okay? And this wire is there to help. It should allow concavity of the intra-articular surface and tensioning of the cruciates, all right? And then we fix it with a plate, with a locking plate. It's standard instrumentation. And here she is. Now I've done her, WOMAC score. Her OKS was 46. Her WOMAC score is only 9. The lower the WOMAC score, the better the result. Though the mechanical axis is hardly 50%, because there is congruity of the joint, there's no teeter. She gets relief. And we can combine the osteotomies for the very large deformities. This is the graphic that shows the L-shaped osteotomy elevates the condyle. We fix it with screws or the half pins. A second osteotomy allows us to correct the mechanical axis alignment also. So here the presumption is that alignment is secondary, but the intra-articular congruity and weight-bearing surface mechanics and stability of the joint is more important. Here she is, we could fine-tune the correction, and I have done her WOMAC score and it is only 6 out of 100, which is very high. She does all the household chores. She can bend down on the floor and mop it also. And she's extremely free from pain. And I thought I will end with another intra-articular osteotomy with your permission. Even in the hips, Drawer is also written about these. So this is a 20-year-old boy. You can't do a THR on him. Everybody wanted to do a THR. He didn't want one. So you do an intra-articular osteotomy. I wrote this up in Indian Journal of Orthopedics. We do the safe surgical dislocation trochanteric flip osteotomy. You see the central part of the head is damaged, but the medial part is okay. Lateral part is quite good. So we resect the medial part. The blood circulation is intact. We coapt the surfaces. This is an intra-articular osteotomy. Get rid of the central part. The femoral head is reasonably round. This is how it looks. And can you believe it? This is 7.5 years after surgery. He has zero pain. He can walk for 7 kilometers. The only thing is he cannot rotate completely. He can't sit cross-legged, okay? But he has zero pain. In very young people, Drawer has written about this, okay? Many cases he has done, much more than Gans and Siebenrock's team. And so intra-articular osteotomies are going to help us. You know, this is a new frontier. Intra-articular high tibial osteotomy, we are beginning to understand. And, you know, I'm going to end with this 5th generation. So the talk was about the evolution of deformity correction and an intimate view. I showed you how I, like everybody else, did the 1st generation. The 2nd generation, Elizarov, I was privileged to learn from Drawer and Elizarov himself. The 3rd generation, I was privileged to learn from the inventor, Charlie Taylor, Professor Charles Taylor. The 4th generation is a combination fixator-assisted nailing and plating, which many of us are doing. We have invented new tools, and now 5th generation. It's a dynamic implant. This is the HTO nail. It's a proof of concept. We did the world's first 5 surgeries with this. You know, NASA rolled back its space program, funding for the space program. So all the vendors, the high-tech vendors in Pasadena area in Los Angeles, you know, Elon Musk has his factories in Los Angeles now, okay? Since the last couple of years, because this whole bunch of people who know extremely high-tech engineering are there. So when the NASA program rolled back, some people turned to medical devices. So they created the precise nail for limb lengthening, which in US and Europe, they use extensively. So as a proof of concept, they wanted to see if this nail can be used to correct a varus. So they came over from Los Angeles to Akola. They spent 5 days with me. And you know, they were filming everything with Google Glass. The chief technical engineer was there, and so was the chief of marketing. And they spent 5 days. We operated on 5 patients, and we saw. So you can see this patient here. This precise nail is inside. You know, there are 2 locking screws distally. There is a mechanism with magnets inside. This is the same precise nail. The only thing modified is the medial-lateral locking screw. A dynamic slot has been created for it, like your DCP slot or your dynamic slot of a nail, so that the mediolateral screw can toggle. So as the nail lengthens over here, instead of lengthening and the same medial opening which osteotomy is done, it opens up the osteotomy. We have to do a little bit of trigonometric calculation because, say, 1 millimeter lengthening here will give rise to much more length over here. So we have to calculate. It's about between 0.5 to 0.6. We have to actually do the measurements and rule of the like triangles to achieve at the result. And the remote controller is there, the magnets. You can program it. It allows you to perform the lengthening. It takes 7 minutes to achieve 1 mm of length. It's very easy once you teach the patients, and they can do it. The kit is given to the patient, and they return it once that is done. And here you can see the patient got a good correction. It came up to about 48% mechanical axis. This was the very first generation. So it could correct only about 11.4, 11.5 degrees. And they worked on it for several more generations. Now research work is going on. Just like the magic nail in the spine, in all probability, they will be able to create a device which allows us to correct the very large deformities. And when they make the device, which can correct 30 degrees deformity and is affordable, that's when it's going to come into practice. But till then, I had the great privilege and honor of participating in the world's first 5G correction for the limbs. And I'm really very grateful to Shiva, to Indian Orthopedic Association, and to all of you for giving me this opportunity to share my intimate journey of deformity correction along with you. Thank you very much. Thank you.
Thank you, Milind. That was a wonderful exposure to all the things which we wanted to hear from you. Thank you very much for taking all the trouble in sharing your vast experience in this field. Can you see my screen now?
Yes, I can.
Okay, I'll just maximize. I cannot see it properly because, yeah. Okay. You said that osteotomy should end at WL.
Yes.
Whether you are doing a supratubercle osteotomy or infratubercle osteotomy, does the endpoint remain the same or it changes?
No, we do a biplanar osteotomy. The idea is to perform a biplanar osteotomy in which what we do is the tuberosity is a zone about 15-20 millimeters long. When you start from the medial cortex, it's at about the center of the tuberosity. You go through the center and don't go up to the tuberosity, stop 15 millimeters short, turn your osteotome so that, the tuberosity is contained along with the distal fragment, but the lower part of the osteotomy continues here until the lateral cortex in this zone.
I'll call you here for a minute. Yes.
So if you stop short here,
yes.
If you stop short here, very likely the fracture line will propagate below or propagate into the joint, which is a problem. But if the fracture line continues to the lateral cortex, so what Stobly is telling us, make an intentional cut.
Yes. I think we are, as a straight nail is used. Okay, this is answered. So my next question is, when you're doing transcondylar valgus osteotomy, which cut is done first in the L cut? Which is first, the intra-articular or the medial cut?
The intra-articular is the important one.
Okay.
So that's done first. And then we do the medial one, slightly sloping, slightly oblique L-shaped.
Now I have got a pleasant surprise for you. One of your first resident or a fellow, Dr. Milind Joshi, who is my neighbor, is here just now. I called him. So these are his questions. Can you tell about your any two worst cases in which you had a complication?
Oh, yeah. So, this statement about complications. If a surgeon says he has no complications, it means only two things. Either he is not operated at all or he's lying. So I told you about fixator-assisted nailing, which got very badly infected. And the patient could not come back to me and he had a very bad result. So that was one very bad case in deformity correction. And there's another patient in whom we did an Elizaro hip reconstruction. And the lady was diabetic and the family would not take care of her. And she developed this problem of fulminant necrotizing pin track infection, soft tissue infection, which is written up in British Journal by Herzenberg, Paley, and the first author is Jarek Quill. Okay, 8 cases, they got fulminating necrotizing cellulitis. So this patient was very severe. She became very bad. She went into the ICU and it took a lot of effort just to save her life because the pin tracks became, but it's the only case I remember in deformity correction. She got very, very bad necrotizing. It's written up. It's not the same as your regular pin track infection. We can control easily. And in the deformity correction over nails, this one patient got a horrendous infection. So now I've stopped. If anybody has had deep infection in the past, never do nailing for them. Never.
Okay.
Never.
Yes. The next question is, how comfortable are you with putting an LCP to protect your regenerate after you have gained the length and waiting for regenerate to consolidate?
Sure. You can, with all these options of hybrid fixation that we have, now people are, there are many methods, lengthening over a nail, or you can do lengthening and then nailing. like Rosbrook has done. You do lengthening first, and then you put in a, he reams, and according to him, the reaming of the regenerate actually improves the healing time, and then he puts in a nail. Now, I'm worried about infection because he is doing it in New York, and we are doing it in our circumstances, in our dusty circumstances. Now, you can put in a fix, you can do lengthening over a plate like Dr. Mrs. Ruta Kulkarni is doing, but the limitation of that is you can lengthen only so much. Lengthening over a nail, I have shown lengthening 9-10 centimeters. But there are people who put in a plate afterwards also. So you can do it if your soft tissues are pristine and if you don't have pin track infection and if your patient does not want to tolerate the fixator and is willing to pay for the price of another surgery, you can do it. You can do it.
Yes. There is a question from Dr. Subramania Gandhi.
Yes.
What is the advantage and disadvantages of doing osteotomy between biplane osteotomy at tubal tuberosity and tuberosity level and inferior to tubal tuberosity?
Okay. So biplane, okay. So the biplane osteotomy for all the precise nails that I did the biplane osteotomy distal, okay? For technical reasons, there wasn't enough purchase. Now they recommend this for large varus corrections. Now I'll tell you, medial opening wedge, large varus correction, you should not do. I'll tell you, don't try to do everything by one method, you know, because if you do large opening wedge correction, there is a lot of literature. So to answer your question, the distally facing tuberosity, where the tuberosity is attached to the proximal fragment, should be done when you want to do a large correction. It will not change patellofemoral mechanics, okay? It will not cause patella baha. It will not cause tightening of the patellar mechanism. And since you're using good fixation, nothing will happen. So, but large varus correction will create problems of its own. A large opening wedge may become unstable. You may need a lot of bone grafts. You're going to have increase in leg length. Do you know if you open 20 millimeters of the wedge, at the center of the bone, you're going to get 10 mm lengthening. So the patient is going to become longer. Then he hates wearing a chappal on the other side, which has got a raise. And then to compensate, he flexes the knee that you have operated and then goes again into flexion deformity and pain. So don't use large corrections with medial opening wedge, whether with a fixator or with a plate. We have to stop thinking, why take home message, kuch to batao, each hum karega. We are thinking surgeons. We are thinking surgeons. We should analyze and do the right treatment for every patient. It's not that difficult. Yes. Large varus correction, no opening wedge.
Okay. The average angle of deformity you have in the cases corrected with HTO?
Yes. Recently we analyzed the last 142 knees we analyzed. We have done medial opening wedge. Our average has been 12 degrees only. 12 mm opening average. The maximum range we have gone to is 15.5 mm. In one case up to 17 mm. For deformities that are larger and need more correction, I am doing a focal dome. And the other cases we are doing intra-articular.
Okay. That question is because that there is limitation of using a precise nail. You said that it is 11.5 degrees.
Forget precise nail. Forget precise nail.
Okay.
It's not practical. It will cost 15 lakh rupees and don't bother with it.
Okay. Dr. Subramania Gandhi again asks, what is the medical treatment protocol for delayed regeneration?
Medical treatment for delayed regeneration? Okay.
Yes.
You can give vitamin D, teriparatide. You can give bisphosphonates orally. You can give a lot of calciums, a lot of vitamins. Make the patient walk, full weight bearing, a lot of walking. Make sure that the fixator is stable. Increase the pins, increase the stability. You can even do bone marrow injections in the regenerate. You can even do bone grafting in the regenerate. You can solve it many ways.
Okay.
Many ways.
Yes. In spite of taking all precautions before removing the fixator, how many times you had a refracture? Maybe at non-union?
Oh yes, this is
regenerate.
Oh yes, this is a very disconcerting complication, and patients are very distraught when it happens. We analyzed our results. We have found so far in the thousands of lengthenings, limb lengthenings, we've had a refracture only on 7 occasions through the regenerate. Okay. And there's usually a cause. For example, you see on the AP X-ray, the regenerate is looking good, but the lateral X-ray, the LRS fixator is blocking the view. You think it's good. You take it out and there is actually a defect. So it refractures. It has happened. Okay.
Okay.
And in the non-union also, it has happened a couple of times. And it's very bad. You know, patient is very unhappy. And you must always visualize very carefully. And there are newer techniques of understanding, what's known as reverse dynamization. This new concept is coming. That's why I'm telling you guys, read JLLR, read the journal.
Okay. I think majority of the questions have been answered. There are some repetition of the same, so I'll not take it. And I thank you very much for the 3 hours. It's really, I had to sit again and watch such a complicated cases being treated with such a beautiful end result. I congratulate you for being the first fellow under Royal Palais and bring back all the best in the world to India. Friends, next week we have got 2 persons talking. On Monday, we have Dr. Tanna, and on Tuesday, we have got Dr. M. Shantaram Shetty, who will be sharing his experience on rigidity fractures and osteoporosis. With this kind note, I would like to end thanking Dr. Milind Chaudhary for taking his time for this wonderful deformity correction webinar. And I also like to thank Dr. Ashok Sham for having done this great coordination work and creating this platform. Thank you very much. See you all soon next week. Thank you.
Thank you,
Bye-bye.
Shiva. Thank you, Ashok. Thank you, my audience. Thank you very much.
I'll leave.
Shiva, we're still on.